nice to have this Sunday morning meeting, and we realized that a lot of people need to do other things on a Sunday, which includes spending time with their families and doing their rounds and so many other things. So we restricted it to a half-day meeting. And we thought that we will make it a little more practical. And we know many of you all treat sleep apnea, recognize sleep apnea in clinical practice, and many of you all treat it with CPAP, and some of you all are not sure when to prescribe it. Many physicians here who have challenges dealing with machines, masks, and patients that have other issues. And so, my name is Sujit Rajan. I'm a pulmonologist, and my colleagues Pratibha Singhal and Aditya Agarwal, also pulmonologists on our foundation, and we sat together and thought that we really need to have, because there's so many meetings and didactic talks, that there's very little time for the audience to really ask the questions they want to ask. And also, communication is a big challenge, which is why we thought after the second tea break and before lunch, we will just have a session where we actually see what challenges patients face, where we will do it with two outstanding palliative medicine specialists who are also excellent communicators, Rajam Iyer and Leena Ganguly, who are both here. One has a background in respiratory medicine, so she knows sleep apnea as well, pretty well, and one is learning sleep apnea well through interaction with pulmonologists. One of the big problems we see in practice is the average time is 87 months, and I don't know if you have met sleep apneics often in practice, but we see it like patients have been snoring for years before they even reach a doctor. And the range is from 1 month, which are very astute patients, but that's rare, to years before diagnosis. And the average time to even refer for testing once you suspect it is about 8 months. And I see this very often, that a patient is written a lot of tests, but the sleep study tends to be the least priority for the patient. And we'll try and figure out why that is. And lack of reporting and not taking, of course, sleep histories. And in the sleep history, these things are very important. And Shivani and Saurabh, who are our faculty from outside Mumbai and both very entrenched in sleep medicine, are going to take you through how to take the sleep history and also when to think about it. And we have areas like escalating. In fact, my commonest referrals as a pulmonologist come from the renal specialist. I was surprised. The renal specialist of all the specialists, that is actually quite late. They've already developed CKD, and it's sad that you get referrals so late. Atrial fibrillation, so common in the elderly, normal tension glaucoma, and a lot of other patients with excess daytime sleepiness. So there are all kinds of specialists that see it, which is why primary care or a general physician to me is the most important filter area for a lot of these patients. And so if they're even sensitized about it, you could make a huge difference to their lives and their health. And what does this obstruction do? As you can see, the obstruction causes an apnea that causes an arousal with increased sympathetic activation, systemic vasoconstriction, increases the workload on the heart, and by that it reduces oxygen supply to the heart, and that hypoxia wakes up the patient, and that causes the arousal. So you have all these challenges. This is what's happening in the system. And before I conclude and invite Pratibha to introduce the first speaker, I want to just tell you what happens in 2025. This is what I've seen, and many of you all have different experience. Someone gets a home sleep study done. It's usually unsupervised. Fair enough. Told to buy CPAP or lose weight. I'm sure many of you all have heard of this story. And we have other specialists here. We have dentists in the audience, and we have a dentist in our panel also. If intolerant to the CPAP, they're given a bilevel PAP. It's like nobody's even thinking what or why should they use a bilevel PAP and what's auto bilevel. And if they're tolerant to the CPAP, the success story ends there and there is very little follow-up is what we've noticed. And this is, I'm talking about physician level, primary care level. So it's, and I would say this even happens probably with some pulmonologists who don't want to think beyond just the machine and whether the patient is actually using that machine, changing his mask. And by the way, we have a stall of ResMed outside who's our funder. I have to thank ResMed for helping funding a lot in this meeting, getting our speakers, helping us to get our speakers here. And ResMed's machines, their masks, their interfaces are all there on a stall for those of you who want to see that during the tea breaks or at lunch. After the CPAP machine is prescribed and the patient is using it well, both the patient and the doctor have lost interest in their sleep apnea. It's like, okay, they must be using it correctly. This reminds me of asthma, where once you prescribe an inhaler, you just assume the patient is using it correctly, and 8 out of 10 times the patient is not using it correctly. What we expect and why this meeting is happening today is that there's more time understanding studies, and at least physicians can look at a study and understand it, explain that report to the patient and the parent, and sometimes it's a child who has sleep apnea, and explain all options, both ENT and dental. Fortunately, we don't have an ENT surgeon today, but I'm sure our pulmonologists will be able to throw some light on how important an ENT surgeon is also. The ENT surgeons with interest in sleep apnea are few and far beyond. So all options are there. And listen to the tolerability. If a patient hasn't used the machine, why hasn't he used the machine? Because a patient who uses the machine is a patient who will tell 10 other people why that machine is so important to their overall health. And it's not a drug with side effects that a drug has, as we know. So find your respiratory physician if you have challenges who has interest. Find your pediatrician or pediatric dentist who has interest. And see what they could be missing in the upper airway. And of course, the ENT surgeon with interest. And finally, the last part of this morning's session, and we are at 9:09, so we are on time for Shivani's introduction and talk. These are challenges we have seen. And so when Pratibha, Aditya and I were talking about what we should do, we have so many sessions on sleep apnea, meetings, conferences, but no one talks about how difficult it is to prescribe a test, which we all have challenges on, I'm sure. Getting a patient to actually rent or buy CPAP, and we have enough patients in South Mumbai with all the wealth who buy a machine and don't use it. So that's another problem, or have challenges using it. So we have actually a real patient who signed an indemnification to act out his challenges, and also insomnia, because we pulmonologists call ourselves sleep specialists, and then we'll have an insomnic patient coming into our clinic. And so insomnia is not as simple as prescribing a sedative. And Prakhar Jain, who's an outstanding psychiatrist at this hospital, will also be there to take us to how to manage insomnia in physicians' practices, and for that matter, in anyone's practice. So thank you very much for coming in on a Sunday morning, and I invite my colleague Pratibha Singhal, who's a pulmonologist and an interventional pulmonologist with interest in sleep medicine as well, to introduce the first speaker and moderate the first session. Thank you.
It's great to see so many people already here on a Sunday morning. So, moving on, our second talk for today would be by Shivani Swami, who is a dear friend. She's also the director of the Department of Pulmonology and Sleep at the Amar Jain Hospital in Jaipur. She's a secretary of the Southeast Asian Academy of Sleep Medicine and very active in the sleep circle. I invite her to give a talk on the types of sleep studies that you could potentially prescribe to your patient and which to choose when.
So I am talking about sleep studies. I think something that really intrigues the general practitioners would be the kinds and the types of sleep studies that we already have, and of course there are a lot of them coming into the market to add to the confusion. So sleep disorders, like sir has very correctly explained, has a huge healthcare impact, and also not just health but also affects the patient's quality of life, and hence the palliative care is extremely important. Of course, the general practitioners are usually the first point of contact for patients, so it's extremely important that it's maybe picked up at that time and early on so that the comorbidities can actually be avoided. When we talk about this types of sleep studies, we need to understand that these types are largely because the American Academy of Sleep Medicine has divided them as such, which is type 1, 2, 3, and 4. This was historically done for insurance purposes because their sleep is covered by insurance, so for reimbursement and all that. However, this is the one that has actually been followed internationally, and that's why we talk so much about it. But then this was many, many decades back, and of course, a lot has changed into sleep and sleep diagnostics as well over the years. So we historically talk about the type 1, which is considered the gold standard and measures a minimum of 8 channels, which must include a EEG, EOG, ECG, EMG, the airflow, respiratory effort, oxygen saturation, and body position. Now, this is something that is done in the hospital, supervised. The technician has to be there watching over the patient. Of course, it has its own challenges because patients are anxious about sleeping in the hospital, a new environment. Some people do not even like somebody watching over them while they, sleep. So all of this can be, of course, a bit unsettling for the patient. Having said that, that still remains the gold standard for diagnosis and is used for diagnosing not just sleep apnea but all complex sleep disorders as well. However, it's definitely more expensive, the added cost of the hospital bed and other infrastructure, the travel inconvenience because the patient has to come from home, spend the night in the hospital, go back the next morning. Of course, it's a foreign environment. The first night effect is a very well known phenomenon wherein you do not actually get that kind of a sleep on the first night in a new environment. And you definitely, when you're talking about level 1, you definitely need somebody looking at the raw data. Otherwise, it cannot be a complete level 1. If the technician has done it, the technician has no idea what has happened and nobody has gone over the raw data, then it does not suffice to be a level 1. Then there is a level 2, which is a similar study but can be done at home without the technician being present. So I said traditionally this is how it was divided. I think in India we have another something which is between level 1 and level 2 where the technician actually goes and spends the night at the patient's house. So that's obviously not divided into this traditional system, but that also exists and people have been doing that. So these are the PSG channels that we usually see in a level 1 and a level 2. When we compare a level 1 and a level 2, the level 1 may sometimes also have a audio video recording along with all the other parameters, which is not possible in a level 2. Of course, a level 2 is done at home, so the cost is a little lesser. And waiting period, I'm not sure. In the private setup, I think there's hardly any, but however, in the government setup, the waiting period even for a level 1 is much longer. So the level 2 and level 3 sleep studies, which we largely call the home sleep apnea testing. Now there's also a myth that a level 3 sleep study is only a screening study. Hence I'm putting this up that is not so. Even the American Academy says that for select patients, a level 3 sleep study can be considered diagnostic. However, the choice of the patient has to be correct. So who are those patients who have a high stop bank high stop bank score over 5? Or these are basically the subset of patients who have a high clinical probability but do not have comorbid conditions. So those patients would actually be ideal candidates even for a level 3 sleep study, and you can diagnose them to have sleep apnea if the AHI is significant on the level 3 sleep study. However, we must always keep in mind that if the level 3 sleep study does not show a significant AHI, that is when the patient should be prepared to undergo a level 1 sleep study, because if they have a high clinical suspicion, because you cannot completely rule out sleep apnea, because the level 3 study is actually not giving you the other parameters, as in the sleep time, the duration that the patient has actually slept. What this is actually looking at is the total recorded time, which we do not know how much the patient has actually slept. So it may sometimes underestimate the severity of the problem. So patients with high pretest likelihood of moderate to severe sleep apnea may be used to diagnose obstructive sleep apnea when utilized as a part of the comprehensive sleep evaluation. So there you could actually use a level 3 device. So now there are many in the market actually. Apnea Link, which is the one that we use very often, where is also one of these. So what we do usually see in a level 3 study is nasal flow, respiratory effort, oxygen saturation, pulse, snoring, sometimes body position as well. So now only to show you how the epochs actually look of the various sleep studies. So this is a level 1 sleep study, and if you see closely, it gives you a lot of data, which is of course the snoring, the respiratory movements, the effort, the saturation, ECG, EEG, and if you look very closely, sound. So you can actually see cessations in breathing here, snoring, saturation, everything. So this patient does have sleep apnea. Now if the same patient was to undergo a level 3, this is how it would look. So you can still obviously see cessation of breathing. He definitely has sleep apnea. You can look at the saturation, snoring, you can look, body position you can find here. And this is how a level 4 sleep study looks. So practically just a pulse oximetry overnight, and you can't really know much other than just the saturation. So of course, however, it still has a role in practice, and it is for maybe population based ruling in sleep apnea rather than ruling out sleep apnea. So this was the traditional system, but with the advent of technology, now there are many more into the market. Some of them are PPG based or PAT based, which is peripheral arterial tonometry. Others are also non-PAT based. So I'm just going to name them. The OST, which was a ResMed product, which I think is now going to come back into the market. The beauty of the product was that it could do multiple nights. So if somebody is not slept one night, this one is doing multiple nights, so you can actually look at the pattern for different nights. And it is disposable. There is the balloon ring, there is a sleep image, SOMFIT, NSleep, and ENSO Sleep PPG. But there is also the watch pad, I think, which I have not mentioned here. Then the non-PPG or PAT based, which could be sound based or again actigraphy based, which is the Sunrise or the Vesper Lab, and the sound based are AccuPebble and Bresto DX1. So this is when we talk about majorly the types of sleep studies. However, to add to the confusion, we also talk about the classical twin night or the split night. So the twin night is where the first night you're doing a diagnostic study, the patient is found to have sleep apnea, and then you want to titrate him to PAP therapy, which is again a tailor-made therapy, so titration is needed. So the next night, patient undergoes a titration study to see his pressure requirement and how he actually does on the PAP therapy, if he's had enough REM sleep, if his AHI has been controlled, and all of that. That's how you do that is actually the traditional method of doing it. However, there is also the split night. So for a split night, it's important that the patient undergoes a level 1 study, because if there's nobody watching the patient, then of course a level 1 cannot be converted into a split night. The other thing that is important is that the patient is aware that we would probably be subjecting him to a split night study, wherein we give a trial of PAP therapy in the second half of the night. So the technician A has to be trained enough to be able to recognize that this is a candidate who would be okay to go through a split night in terms of AHI, because that is the criteria. So when we say about split night, the patient actually must have a AHI of at least 40 during the diagnostic period, or should have a AHI of between 20 to 40 with long apneas and significant desaturation. So those are patients who are actually candidates for split night. Not everybody can go through a split night. So when you see a patient in the clinic and you feel that this is somebody who would probably have moderate to severe sleep apnea, you explain to them in the clinic that they might be subjected to a split night, so that in the middle of the night you slap over somebody's face a PAP mask, they might actually not tolerate it. So the patient must always know what is going to happen. That is the basic part of preparing the patient for a sleep study, that you explain. But however, of course, there's a very delicate balance to be maintained there between explaining to the patient and scaring them off, because of course it's not pleasing to see somebody undergo a sleep study. You have to answer all their basic questions like what medicines they can take, what time they're supposed to have their meal, how are they supposed to prepare, like for men especially, ask them to shave, and for females and men, maybe have a head bath, because even the oil can actually interfere with the electrodes. The most common question that we also get asked is the medicines that they can take. So if there are any regular medication that they have been taking, they have to continue taking that. However, if there is something that needs to be stopped, as a physician or as a sleep physician, you feel that this medicine is going to interfere with the study, needs to be stopped, then the washout period has to be adequate, a minimum of 7 days. It's not like I can stop the medicine today and then subject the patient to a sleep study tomorrow. So those are things that we must really keep in mind. And as far as going back to the split night, so then of course, like I said, the technician has to be there to be able to do it, and it has to be a trained technician. If the technician is not trained, best is to do an overnight sleep study and let a qualified sleep practitioner look at the raw data and decide if the patient actually needs titration. And the one parameter that we've always talked about when we talk about sleep study, it may of course be overrated, however, still remains one of the basic parameters, which is the apnea-hypopnea index. Apnea-hypopnea index is the average of the number of events of apneas and hypopneas that the patient is having during the night. We say 5 to 15 is mild, 0 to 5 is normal, 6 to 15 is mild, 16 to 30 is moderate, and over 30 is severe. However, there are other parameters that need to be looked at, which is the ODI index, the oxygen desaturation index, wherein we need look at the number and the kind of desaturation that the patient is having, and many other indices. And to summarize, a complete overnight level 1 sleep study monitors EEG, ECG, EMG, airflow, respiratory effort, and it is the gold standard not only for obstructive sleep apnea but also for complex sleep disorders like probably restless leg syndrome, periodic limb movements, parasomnias, and all those. Level 2 is a comprehensive portable sleep study which has all the parameters but is done at home. It is usually used for diagnosis, especially in patients who do not sleep well in a new environment. It can definitely be used. Level 3 is a limited channel portable sleep study done again at home. It can be done in patients who are suspected to have moderate to severe sleep apnea on clinical picture. And then there is the level 4, which has very limited clinical setting. It's basically just population-based screening. So all the sleep studies actually have a place under the umbrella. It just when to use which one, that we have to be extremely cautious about as physicians. And just to add that the polysomnography labs are also used to do MSLT, which is the sleep latency test, which is used for diagnosis of narcolepsy, and the MWT, which is basically used to assess alertness of a patient, especially if they are on PAP therapy or any other therapy for sleep apnea, and we want to assess if they are fit to do high attention jobs like driving, etc. So early recognition of sleep-related breathing disorder and of course early therapy is important to rapidly eliminate its symptoms and to avoid the occurrence of typical comorbidities. And I think this is one of my favorite authors And if any of you are actually interested, you should listen to this podcast by Matthew Walker. And if you're even more interested, then read the book. So I think he talks about sleep very passionately and definitely very scientifically. And that does make me believe that sleep is one of the best medicines that we can actually provide to our patients. Thank you. So, ma'am, usually we say that there are lots of medication like a few antidepressants and especially the benzodiazepines and all which interfere with the sleep pattern. It's not necessary that you stop all of those. You have to take a conscious call. If the patient has been on a sedative for years, then that's actually his usual pattern of sleep that we are wanting to chase. If we stop that, then the patient is actually going to have withdrawal, and that's not going to be his usual pattern of sleep. So we don't stop that. However, if the patient has only taken it for maybe 5 days, 10 days, then we give it a washout period of say 5 to 6, 7 days, and then do the sleep study to eliminate the crossover effects. Yeah, sure. So, sir, you usually don't stop anti-allergics immediately because even when the patient has nasal congestion or nasal symptoms, even that actually interferes with not just the sleep, but also if the patient needs PAP therapy, then the titration. So we can switch them over to nasal decongestants and then stop it. So alcohol, yes, ma'am, very good point. So I was going to cover that in my next talk. However, so somebody who's drinking every day, that's also one indication of level 2 study. So somebody who consumes alcohol every day, it's a challenge to, call them to the hospital and undergo a level 1 sleep study. But that's their routine sleep. So if that's what we're looking at, then we do a level 2, let them have whatever they've been consuming, and then make them go through. But if it is just social drinking, then of course we ask them to avoid alcohol.
I think, Shivani, there's a lot of physicians in this group, and I doubt they will be doing split nights, too many of them. So, could you tell us what you think a physician, a primary care physician who sees multiple patients, how do they decide whether to do a type 3, 4, which is not difficult for them to do, I think, versus sending it to a pulmonologist for more detailed studies, which I don't think the majority of patients could be done, studies could be done at a physician. So how do they decide that?
So,
ask the spouse to take a video. The spouse or the partner to take the video during the sleep. That gives the first this thing. You can actually make out what is going on.
yeah, absolutely, ma'am. Can't agree more. In fact, a lot of the female spouses get their husbands' videos.
So we can take a sleep history for each patient, all our chronic patients. Do you snore? Do you snore? We can include in a routine history taking.
So I did not talk about history taking because Dr. Saurabh was going to cover it. But classically, a patient would come to you with snoring, excessive daytime sleepiness, disturbed nighttime sleep like waking up intermittently to go to the washroom, and tossing and turning in bed, waking up to drink water, feeling the throat is parched. Of course, the spouse or the bed partner is also going to say that they have very disturbed sleep. They may also talk about witnessed apneas. The patient might wake up in the morning feeling groggy, not fresh, wanting to sleep more, with very often having morning headaches. Those are the usual symptoms that we see in these patients. However, we also have to keep an account of the comorbidities. So the comorbidities being uncontrolled hypertension, uncontrolled diabetes, arrhythmias, any cardiac events they've had, congestive heart failure, any neurological events. So all those are also comorbidities, CKD like sir said. So all those are also factors that we need to actually keep a watch on. So when to do a level 3 sleep study is if a patient has all these symptoms, has a high stop bank Dr. Saurabh is going to talk about, so I have not covered that. So has a high score on stop bank and has these symptoms, and other than that has no comorbidities. So that is a patient where you are not expecting a complex sleep problem. It looks like simple sleep apnea. That is where you can actually go and advise a level 3 sleep study. However, if the patient has cardiac failure, has a history of stroke or CKD, those are patients who might actually have a complex underlying sleep problem, so not candidates for a level 3 sleep study. Those are the ones who ideally need a level 1 sleep study. Yeah, excessive daytime sleepiness.
Yeah, well, that's a good question to routinely ask your patients about their sleep, because sometimes patients don't often tell you that they have these issues. And when you ask them these pointed questions, they say, but it doesn't matter. My partner also snores. We both snore happily and sleep. So, it's a good point that we should ask sleep history in our questionnaire.
Yeah, absolutely. Because Indians, I think they believe that snoring is
It's
a sign
healthy.
of good
It's
sleep.
healthy, yeah.
Good
Nothing that,
healthy
yes.
sleep. True.
Patients with ILD, when do you advise sleep studies?
So patients of ILD, I think sir would agree that we advise sleep study if, we feel that it's an advanced disease. We always advise them at least a screening sleep study to look for nocturnal desaturations. If they are not maintaining on the classical therapy, if they have dyspnea or excessive dyspnea in proportional to the disease, if they have improportional pulmonary arterial hypertension in proportionate to the disease, and also if their exercise tolerance is low sometimes, even in those patients, if it's not explained only by the ILD, then I do advise. Sir, would you want to add anything?
Yeah, just to add there, Shivani, you can get away with the type 3 study very often in an ILD patient. A lot of them have reflux and they have sleep apnea as well. So reflux aggravating the ILD, a lot of medication going on. The information you need is basically, are they desaturating at night, which Shivani mentioned you will get with an overnight oximetry. So you find a vendor who you work with, right, who will do an overnight oximetry. It's a very underused test, I find, in clinical practice. And it's simple and it's not that expensive, and you know whether your patient needs nighttime oxygen with ILD. Now, the point you asked was, when do you do the sleep study? Do you have obstructive sleep apnea? That you will need at least a type 3, which means 4 or 5 channels to know whether the patient is obstructing also. So why is the patient dropping oxygen at night? Is it because of sleep apnea or because of his ILD? That's the question we need to answer. Am I right, Shivani? And so I often get that answered in patients who can't afford a type 1, type 2 study with a type 3 study itself. But sometimes it's a little more complex, as she said. If they have other comorbidities, then you're challenged. So type 3 studies, I feel, in primary care can be used quite easily. They're not expensive. And the most basic, as someone said, if you're snoring excessively, daytime sleepiness, the history tells you. But you still need a test, right, to document it. I mean, for all kinds of lung diseases, we use tests. Here we sometimes are not able to even move that first step forward, I find. How have you dealt with this challenge, Shivani, where patients are a little, or do they, what's your advice to physicians here on testing?
So it's very interesting, sir. Only yesterday I had a patient who came to me with symptoms of sleep apnea, and he brought a CPAP machine. That I have this machine since the last 1 year. I have not begun to use it because a brother stays in the US and he sent it, and I haven't happened to use it. And I was, after all this, like, okay, please show me your sleep study. He said a sleep study hasn't been done. He hasn't even consulted a doctor. He happened to mention to his brother who lives in the US, and he has just sent the CPAP. And a study has not been done. So I always tell them this is like looking for refractive error. Unless you've checked that you do have a problem with your vision, you do not go and just start putting spectacles. You look for A, of course, if you have an error, and two, what is the degree of your error? What is the kind of correction that you need? And only then, so this is exactly like that. A, you need to first identify the problem, and B, then undergo a specific titration for what kind of therapy works for you, and then start using the therapy. It's not like, it's very tailor-made therapy. It's not one size fits all.
Absolutely. I mean, it's like, it reminds me of an asthma patient using an inhaler without a spirometry test, right? He's never had it, yet he's feeling well with the inhaler. So I'm wondering whether sleep apnea will move like that in the very obvious sleep apneic. Would you advise, as a patient comes to you and says, look, I'm happy to use the machine, my brother has sleep apnea. I don't want to do a study, just prescribe a machine. Have you ever had that from a patient?
But sir, like yesterday, it was almost like that, and I told him, you have to just go through a study. And honestly, this patient actually had very weak symptoms. He was probably having a witnessed apnea once in months. So his frequency actually wasn't that
Wasn't
much.
that high. It wasn't that obvious, yeah.
How do you manage a patient whom you have advised a sleep study and has not been able to sleep at all because of the wires? You do have patients like that, right? Who say, I couldn't sleep at all, and they're obvious sleep apneics. In that situation, how would you deal with it? They're refusing to undergo a sleep study.
So ma'am, level 1 I think is a usual challenge in that perspective, and sometimes even level 2. So for those patients, I repeat a level 3 sleep study. But even the level 3 sleep data, I want to look at it manually so that I won't know the sleep stages, of course, because it does not have EEG, but at least I know that the patient is actually having respiratory events or while he's sleeping. So that also gives me a clue. And if I still have to repeat a level 1, then I try and do a level 2, and of course tell the technician to stay over so that if a lead comes off or the patient feels any hassles, then it is addressed at home only. And of course that also gives the patient more confidence that there's somebody who will be able to handle and remove it in the middle of the night if needed. So I think if at all needed, which is a very rare occurrence, those patients are able to manage on the second or the third, because by that time I think they're also more mentally prepared to sleep with all of that.
So basically, we are dentists, so actually we do the screening while having questionnaires and everything. But are we allowed to advise a level 3 study? Usually I refer to a sleep physician.
Yeah, so ideally, I think medico-legally at least, dentists are not yet allowed to order a sleep study. Yeah.
It's right. Like that's how we usually, when we suspect, we refer it to a sleep
Yeah,
physician.
I think so far that's how it is.
Thank you.
Like in asthma, everything that wheezes is not asthma. Everybody who snores is not sleep apneic, right? So what do you do to those middle grey people? For example, yesterday when I was coming, there was a loud snorer next to me on the flight. I really wanted to wake him up and say, hello, get your sleep test done. But it's very embarrassing for him. Probably he doesn't even realize he's dozing off and falling all over the place. But what do you do for people who are not fitting into your sleep study criteria of AHIs to put a mask? At the same time, they're loud snoring. And how do you follow these people? Because they might think you're just fleecing them by doing expensive tests and prescribing all these things.
I'll send them to the ENT, ma'am, to look at the upper airway.
And being a dentist, this middle age can benefited by oral appliances where we protrude the jaw, increase the airway, and
Yeah,
so
depends upon the upper airway
obstruction,
and the
yeah,
level of obstruction.
level
That's why I
of
did not
obstruction.
specify that.
Yes.
I think we have.
We have a lot of people undiagnosed, with a lot of people under the tip of the iceberg. We are not still very much sleep aware.
I think we still have a lot of population even over the tip of the iceberg, ma'am. So definitely we are not at all sleep aware.
We have Shivani most of the morning, so Shiva, we have to move, and there are 2 tea breaks. There's one more talk of us, so please. In fact, I really want to know what challenges you all face in sleep study. I was surprised to know that dentists cannot order it, but patients can order it through ResMed, I think, a sleep study, but dentists can't. That's not fair. So anyway, we'll come to all that as we go along. And Pratibha,
Can I take Sujit?
yeah, Pushkar, please.
These smart watches, will they replace sleep studies, or this night owl study which is temporarily out of market, will it replace sleep study?
So I think what it will do is that it will definitely increase awareness and get people talking about sleep and looking at their sleep patterns and probably coming to a sleep physician for sure. They may not replace completely the diagnostic ways, but it definitely has a place in screening and also, of course, increasing awareness.
Is there a smartwatch available which is giving AHI or events per hour right now in market?
No, I don't think so. So it's actually only overnight oximetry, so it's practically a level
But
4.
the smartwatches talk about REM sleep and everything they come up with.
They do, but we don't,
That,
and it has actually also been approved by a lot of associations and they talk about, but then again.
Treating physician, it becomes difficult when the patient comes with the watch and just shows, and then they expect the doctor to know that how to interpret that, and so I think that should also be part of your talk, maybe how to interpret the smartwatch data.
Yeah, I think it can be a different talk in itself. Yes, sir. Sure.
Okay, so thank you, Shivani, for that lovely lecture. Moving on, we have with us Dr. Saurabh Mittal, who is an assistant professor from the pulmonary department at AIIMS, and he is going to talk to us about different types of PAP therapies and how do you choose.
Good morning, everyone. So I think just answering the question on smartwatch. So there are only 2 smartwatches which are actually approved for the suspicion of sleep apnea. So once we have is the Samsung Galaxy Watch and the Apple. So these are the 2 versions, Apple 10 I think. So those are the only 2 which will give you a reading that you are likely have sleep apnea, please see a physician. So it is not a replacement for a physician, it is not a replacement for a sleep study, but it is just for recognizing determination for the patient that they may have sleep apnea. So I think the stages also which they give, a lot of them will give. If you buy 1,000 rupees Fitbit, it will give you something, everything gives, but those stages are in whatever I have seen are not very good, but what it definitely does is that it brings the patient to a doctor. That's the only thing they can do best. Okay, so now after these studies, we'll be talking about PAP therapies. So when and for what, probably my next talk I will cover the evaluation parts also, but first we'll talk about the PAP therapy. So PAP means positive airway pressure. Okay, so positive airway pressure is something that you apply a device to a patient, it gives them a pressure, it keeps the airway open and it works. Okay, so that is something which we all probably have learned over the years, but the problem is, what is the problem with PAP? The problems which we as general physicians or pulmonologists find costly, bulky and non-acceptable to the patient. Yes? So that's where the entire problem of PAP therapy over the last 2-3 decades have been roaming around. So I'll tell you how to select a device, but yes, it needs a lot of motivation from the physician side and the patient side, so to have a good optimal outcome on a PAP treatment. So when we talk about PAP therapies, we talk about the right device, which device to choose. We did talk about right settings, what settings we should give, what is the interface, and then how do we monitor these patients. So I'll not cover all of this because of the lack of time, but I'll give you some overview of PAP devices. So when we have a patient who has been diagnosed with sleep apnea, okay, whichever severity, mild, moderate, severe, what is the aim of our therapy? What is our aim? We have a number on a sleep study. Number is 65, 23, 19, 21. We want to bring that number down. Yes? So we want the reduction of AHI. Okay, so we don't know how it will translate into patient's quality of life, but we want to bring that number down. So that is one aim of therapy. Then we reduce the AHI. We reduce the patient's symptom. Daytime sleepiness, fatigue, morning headaches and other symptoms. Also, we want to look at whether we can improve their comorbidities. Specifically, a lot of research has happened on the cardiovascular consequences of OSA and whether a PAP therapy can reduce that. So that's a topic of debate, but that's a physician's aim that yes, by PAP, we should be able to reduce their cardiovascular comorbidities and mortality. So this is our aim, but do all patients need PAP therapy? So that's where, so if you have learned mild, moderate and severe, so in general the concept has been that moderate to severe sleep apneics definitely need treatment. And mild sleep apnea, that means AHI less than 15 with symptoms need treatment. Yes? So remember this. But what this 2019 guidelines brought, just focus here. I think it's not seen there. Okay. So excessive daytime sleepiness. If patient has excessive daytime sleepiness, they need a treatment. If they have poor quality of life because of sleep apnea, the quality of life can be anything. They have fatigue, their partner is disturbed, they are having a divorce-like situation in their family because of sleep apnea. They have erectile dysfunction. So whatever be the quality of life disturbance by sleep apnea, the patient needs treatment. And if they have hypertension, they need treatment. So this is very important for general physicians that hypertension is one of the commonest comorbidity of obstructive sleep apnea. So if I see practice, we see hypertensive at age of 30, 32, 33. And if we screen, a lot of them will turn out to be sleep apneas. Yes? So that is very important that once you have a young hypertension, always look for sleep apnea. So what are the benefits of PAP therapy? So daytime sleepiness improves, hypertension improves, and motor vehicular accidents improve. This is proven that if you give treatment to your patients with OSA, they will improve. But neurocognitive improvement, cardiovascular risk or arrhythmias, there is not a very definite evidence, but there is some evidence that they tend to improve the treatment. So that's what I'm trying to tell you, that whenever you counsel a patient that you have sleep apnea and I am advising your therapy, you may have a benefit in all these problems rather than just your sleep. Yes? So this is very important. It's a systemic problem. So sleep is what affects the entire body, not just brain or eyes or anything. So how PAP therapy works? So this is probably a small video. So you see, this is how the sleep apnea happens. So there's an obstruction and airflow stops. Right? So that's where the sleep apnea happens. How PAP works? So you have applied a PAP. So it pushes air and it keeps this air stented. This is called as pneumatic splint. So this does not fall back and this area is maintained by application of a positive pressure. This is how the PAP therapy generally works. So you can have these videos are available online. You can show these to your patients that's how the thing works and they would probably be more adaptive to your listening and your counseling. So PAP therapy has actually been simplified a lot over the last few years. So if you see PAP devices which were there 20 years back versus today, there's been a lot of improvements which have happened. We have very small devices which have come into the market. So you can have pick and choose method whenever you are having a patient whom you are prescribing a PAP. Always have a baseline knowledge that what is available in the market, what will be acceptable to my patient, and what I should show it to them so that they can be more receptive to it. Okay. So this is the crux of what I'm going to talk about. So there are multiple devices. So there are 6 things which I have written here: CPAP, auto CPAP, BiPAP, auto BiPAP, ASV and VAPs. Okay. So the last 2 are not part of my discussion at all. So ASV is for central sleep apnea. It's not primarily for obstructive sleep apnea. And VAPs modes are for hypoventilation. Okay. So just forget these 2, but the upper 4 are what I'm going to talk a little bit more about. Okay. CPAP, BPAP, auto CPAP, auto BPAP. So before I go to the notes exactly, I'll show you what a device looks like. A lot of you might have seen a device, but I'll just brief to you that what a device is. This is a device which has a flow generator in it. Then it has a humidifier generally. It has wirings. It has a tubing. And it has a patient interface. So these are the 4 things which make up a device. And as a physician or as a clinician, we need to focus on all 4. Okay. So it cannot happen that I give them a good device but a bad interface, they would be acceptable. No. So we should have everything on focus. The tube should be of right types, the humidifier should be there. Whatever we are looking at, we need to focus on all 4 types of a PAP, things in a PAP therapy. Okay. So what is CPAP? CPAP is easy. Continuous positive airway pressure. So you have a patient and a fixed pressure is there throughout the night. So this CPAP is applied using the interface throughout the night. And how to know this pressure? That is known by a titration study which Dr. Shivani was talking about. You have a patient who has undergone a sleep study. Now you do either a split night or a full night titration. So you have found a pressure which is required to eliminate all events for that patient. So once you have found, supposedly it might be 11, 11.5, it might be 12, whatever be the pressure, you prescribe that pressure and the device is fixed. This is called fixed CPAP pressures. Okay, so this is the commonest kind of thing which has been used forever for treatment of obstructive sleep apnea. Now we have BiPAP. Okay, BiPAP, as physicians we all know, BiPAP means two pressures. So BiPAP will give two pressures, one is IPAP and one is EPAP. So BiPAP is not for all. Very important thing. BiPAP is for very small proportion of patients of obstructive sleep apnea. And which are those patients? When patient is uncomfortable or unable to tolerate a CPAP because of high pressure requirement. A patient who is requiring a pressure of 18, 17 on a CPAP and has a problem in exhalation, you may switch them to a BiPAP. Not everybody. Or if patient has persistent sleep apnea, even if you have reached a CPAP of 20, because CPAP devices can give a pressure only up to 20. So if patient's pressure requirement is more than 20, you have to switch them to a different device. But in general, when a patient has a pressure requirement more than 15 on a titration studies, we tend to give them a BiPAP because supposedly if today they have a pressure of 17 and in next 1 year they gain 10 kgs weight, they would require higher pressure. So if their pressure limits are higher, they generally prescribe a BiPAP if their pressure requirements are above 15 in general, but that can vary from practice to practice and patient to patient. But very high pressure requirements, you may switch them to BiPAP, not for everyone. This is very important because I see a lot of BiPAP prescriptions from the physician side. The patient is not using CPAP, give them BiPAP, and the BiPAP pressures are also very low, 6, 12 or something like that. So that is not the right way to treat sleep apnea. Now we talk about the auto CPAP. Okay, auto CPAP is something which everybody prescribes and everybody does. So what auto CPAP does? Auto CPAP, so if you look at this fixed CPAP, it gave a fixed pressure throughout night. But auto CPAP will keep changing the pressure. And how will it do that? It will sense the patient's breathing, the area I showed, whether it is closed or open, and depending upon the need of pressure, the machine will sense and change the pressure. So that's called an auto CPAP. So how does machine do that? Can anyone tell me? How does machine do that? So machine has a software, it has a kind of FOT mechanism. So it sends a signal and gets back whatever it comes to you. It will find out that how much is the aperture or the obstruction there, and based on that obstruction, device will change the pressure. So I think that's the kind of software or algorithm the all CPAP devices companies survive on. So they have their own patented algorithms, and these are generally good algorithms and work fine for most patients. So this is called auto CPAP. The good thing with auto CPAP is that you do not need to do a titration study. Okay. So in general, fixed CPAP is good enough. Auto CPAP has some problems. What are those problems? So supposedly you have put in a mask. Okay. But there's a lot of leak happening to a patient. If there's a lot of leak, device will not function properly. The algorithm on which device was supposed to function will fail. So if you have a lot of leak, your auto CPAP algorithm would fail, right? So if you have a patient who is not able to fit their mask, you have put them on auto PAP, their device will work haywire. So they would not be treated, their device would not, and patient will come to you, the doctor, my pressure is too much problem leaking here and there, and I'm not able to sleep well. So patients who have central sleep apnea, this is very important. On a baseline sleep study, those who have central sleep apnea, they should not be prescribed an auto CPAP. Okay, so these are the two problems with auto CPAP. Then you should actually prefer an auto CPAP. So if you have done a home sleep test and you have not done a titration study, you can prescribe an auto CPAP. So that's probably the easiest indication for everyone which we do. But the problem is just prescription on auto CPAP is not the end of it. You need to follow them up, you need to change the pressure test settings because based upon what you have. So if patients, supposedly you have a patient whom you done a titration studies, you have prescribed them a pressure of maybe 14, but they are not able to tolerate. So it is there that some degree of tolerance can be improved if they are switched to an auto mode. So if you have a patient who is not tolerating the fixed CPAP, you may switch them to an auto CPAP. Or you have patients, they may have different requirements on PAP during the entire night. Like somebody who has a nasal disease. So they have good days and bad days. On good days, their nose is open, they are doing fine, their pressure requirement will be 8. On bad days, if they have nasal mask, their pressure requirement will high because nasal pressure is high. So obstruction is high, so they would require a pressure of maybe 11 or 12. So if you have patients who have upper airway problems which are there and chronic, you prescribe then auto PAPs where pressure requirements would be sensed by the device and it can be changed. Okay. You have patients who are trying to lose weight, who have joined gym, who have taken newer drugs for weight loss. So those who are losing weight or those who are gaining weight, their pressure requirements would change. Okay. So in that situation, an auto CPAP may give a better control of disease rather than a fixed PAP. REM dominant or a positional. So patients who have supine position dependent sleep apnea or REM dominant sleep apnea, so their pressure requirements will be different during different stages and position. So they may be doing a little better on a auto PAP device. So this is nothing absolute. Let me be very clear to you. This is not absolute. This is what is generally practiced, but there is no absolute indication for auto CPAP. If you can titrate them, you titrate them, and you retitrate them. Supposedly somebody is 65 today, he has lost 10 kgs, 55, you retitrate them, give them new pressure, right? So there is nothing absolute, but just for the feasibility purposes, auto CPAP has come and has become like a standard of care. Now we have something called as auto BiPAP also. So auto BiPAP has very limited indications. So in my last 8-10 years of practice, I prescribed 2 auto BiPAP. So auto BiPAP has a very limited role. So auto BiPAP is to be prescribed when you need a BiPAP for a patient of obstructive sleep apnea and they do not have many comorbidities. So you have a patient, so what it does, it gives you an IPAP and EPAP and it maintains the difference is same. So supposedly you start a patient on a IPAP of maybe 16 and EPAP of 12, the device will continue to increase 13 and 17, 18 and 14. So the difference won't change. So this is the purpose of auto BiPAP. So it does not give ventilation. It only keeps the upper airway open. So auto BiPAP is for those patients who require a very high pressure and are not coming to the lab for a titration. Right? So I have talked about 4 devices: CPAP, auto CPAP, BPAP, and auto BiPAP. I have told you what are the indications of BiPAP, what are the indications of auto CPAP, and that's probably all you need to know about the device. So how do we choose a device? So it's an uncomplicated OSA, uncomplicated, no comorbidities. You have done a home sleep study, you can give them a CPAP or an auto CPAP, fine. Either of them is okay. If you have an OSA with comorbidities, severe COPD, severe ILD, hypoventilation, so you may need to give them a PAP titration and give or central sleep apnea, so you will have to give them a fixed CPAP. So auto CPAP is generally for uncomplicated sleep apnea. Or you have patients who have hypoventilation syndrome, overlap or neurovascular disorders, you need to titrate them and they may need a BiPAP or a PAPS mode because of their hypoventilation. And then you can kind of do a lot of troubleshooting while they are on treatment and change the modes as needed. Now I was talking about the second component of the device, that is the humidifier. So as of now, in today's time, most devices do come with a humidifier, which is inbuilt. But I would say like 5-7 years back, there were a lot of devices which were coming without a humidifier. So in general, humidification improves the nasal mucosa function and dryness is reduced. So guidelines recommend that in general, you should prescribe a PAP with a humidifier, in general. So tubings are also of different types. There are simple rubber tubings, there are slimline tubings, and there are some heated tubings. So heated tubings, they do not have water vapors condensed into them. So, depending upon patient's comfort, but we generally prefer heated tubing so that we don't have a water vapor in the tubings, and so patient does not have a water coming into their mask in the winter period. So in winter, what can happen is that if the temperature is low, the water vapor condenses inside the tube and goes to the patient. That's called as rain out. So patients will feel problem in the winters if they do not have a heated tubings in their devices. Now we talk about the interface. So interfaces are many. So first we have to look at the size of the interface. So most of the manufacturers will give you some idea how the size can be done. So there are primarily 2 types of interfaces, nasal and oronasal. So nasal can be nasal pillow or nasal can be nasal mask. Okay. So nasal pillow and nasal mask are generally the preferred interfaces for treatment of obstructive sleep apnea. Oronasal mask or the larger masks are generally have higher pressure requirement, higher residual HI and poor compliance. So in general, for treatment of obstructive sleep apnea, nasal mask or nasal pillows are the preferred interfaces. Right? Now we have something called as hybrid mask. So they have a oronasal interface, but the size is small and they cover a smaller part of the face so that patient can see around, they can watch TV while they are applying the device. So these are called hybrid masks which are new in the market and they are coming up from different companies. So mask selection is important, so you can show different types of masks to the patient and they can decide whichever mask suits them best. Now, a little bit on monitoring. So, everybody knows that CPAP is a problem therapy, yes? You give them CPAP, if you don't monitor them, they won't use it. So, how do you monitor them? So, monitoring is by clinical, you ask them what are they doing, are their symptoms better, and there's something called this device will give you some idea. There are built-in softwares in the device which will give you how the device is functioning. So, it will give you the what pressure they are using, how many times they are using, how many hours they are using, what is their pressure requirement, what is their relief. So now this can also be done from a telemonitoring. So there are devices now available which will give you access remotely to the patient's data. So you can monitor therapy remotely from a software from Respirate, which is called AirView. They have a My Air app for the patients also. So you have to monitor therapy while patients are using the device and give feedback. You can change settings of the patient's device. So you can give that feedback that patient, your device is not functioning fine. You need to come back to the clinic and see me. Okay. Or you can give them a call. Yesterday night you have not used the device. What is the problem? So, I mean, if you have that kind of communication with your patient, you may improve your compliance rates. So just to conclude, so fixed CPAP or auto CPAP is for uncomplicated OSA. Fixed CPAP for OSA with comorbidities. BiPAP for high pressure or intolerance. ASP for central sleep apnea, VAPS for hyperventilation. Nasal interface and humidifier for most patients of obstructive sleep apnea. And we need to use either the SD card data or the telemonitoring service for monitoring while patients are using the data. So that's all on my side. Thank you. So if somebody has done a titration, they will give you the pressure requirement by the technician with the CPAP device. So if it is a home study, generally titration is not done.
But how do we decide how much?
So that's what I was coming to, that if you give them an auto CPAP, you have done a level 3 study, the patient was given a device.
I think sorry to interrupt you, but this is a big challenge in physician care. Auto CPAP or do a titration, because as you were asking, how do you decide the pressure? So should you, I mean, we don't see many fixed CPAP machines nowadays. I see many people being just given an auto CPAP. So what do you advise to? I mean, you showed that report. Can you pull out that report? Because I think as a physician, you can ask the company to get this right for you.
So what we do, supposedly a patient who has undergone a level 3 study. The report comes, the patient has an AHI of 31 events per hour. Now I have decided that this patient does not have significant comorbidities. They are okay, they are obese, they have sleepiness, they don't have cardiac or lung comorbidities. I want to give them a PAP therapy. So what we generally do, we give them an auto CPAP. The pressure setting on the device would be 4 to 20. Minimum pressure would be 4 and maximum pressure would be 20. So that's a default setting comes from the device. Okay. So with that pressure, we generally give the patient, ask patient to use it for 2 to 3 nights. What will happen? The device will capture what was the patient's requirement. So supposedly you can see here, the P95 in this is 15.2. You see this 15.2? So that means 95% of the times the patient's pressure requirement was below 15. Okay. So what I'll do when the patient comes to me after 3 days, I'll switch this device from a pressure range of somewhere 13 to 17. So then the pressure will change from 13 to 17. It will not go too low, it will not go too high. So adjusted. So that adjustment is generally done on the feedback which you get from the device or from your telemonitoring data. So supposedly, okay, now what happens if I don't change that pressure? What will happen? What will happen is supposedly I start the patient on 4. Patient sleeps for the next 1 hour. By the time device will sense the pressures, the 1 hour patient will remain untreated. Supposedly patient's pressure requirement was 12 at that point of time, but the device is gradually increasing from 4 to 5 to 6 to 7. You understand that? So the very low setting will lead to under treatment in the initial part of sleep. So that is why generally Auto CPAP also is not very wide auto. Auto has to be a narrow auto, 12 to 16. Generally, whatever P95 we have, plus 2, minus 2.
And this is a typical report I see. 4 and 20. That means nobody has looked at this pressure. 4 means it's the minimum and the maximum, you know. And what is the role of the physician? The role of the physician is to give treatment, right? And this is 1 hour, as he said, that's a very useful point. For 1 hour, the patient is not even being treated because the pressure is just gradually building up to what they need.
So this pressure generally, so for most patients, this pressure requirement would be generally not very much variable. So supposedly after 3 days I find this, I switch the device to 13 to 17. I call them at 1 month, and so now most of the devices are on cloud, so I can check them remotely and I will know what is happening to the patient. So then we can, supposedly I see a lot of difference happening. Supposedly I have set the upper limit as 17. Okay. And I see P95 as 17. That means my patient's pressure requirement has increased, but they are not able to go beyond that. So I'll increase the upper limit to 20. So for initial 2-3 months, you may need to do this setting, but after 3 months, generally the patients do okay. So we call them for follow-up every 6 months, and they are generally doing well. Yes, so patients can bring the device, you can do it manually. I never teach my patients to do it at their home, because if patients learn, they would do haywire things and I will be in the problem. So, or I can do remotely. If I have the device on a AirView, which is compatible device.
Distributor.
Yes. Companies also do that, though the person who supplies it. But generally, I ask patients to bring the device to the clinic and I do it. Or if I call them, I do it remotely from the AirView software and device gets those settings at home.
They can show it to you on the device outside.
Yeah, so the devices are there outside.
Subhashish will be able to show them how to change those pressures.
I think Respect will show you how you can change the pressure.
The devices are there outside, you can see them.
Okay. So, nowadays, the difference of a fixed CPAP versus an auto CPAP is not too high. I would say the ResMed starting model is somewhere around 30 to 35,000 approximately, and their manual would be 25 to 28,000 was the flight or light mode. So I think now the difference is 5 to 10,000 at max. So in general, even if I have to give a fixed CPAP to a patient, I prefer that they buy an auto device. So I can switch them later, I can do manipulations later rather than doing titrations in the lab every time. So basic model 30, 35, then advanced 60, 65, 80, 1 lakh. So there are different types. So depending upon the need and constraints, you can decide your device.
When we started practicing sleep medicine, the fixed device was much cheaper than the automatic device. Today, the price gap is much less. So most patients, as Saurabh said, will end up getting a auto CPAP. The key issue is you should adjust the pressures, you know, and I think after a year, you can fix the pressure on an auto CPAP also.
Yes.
In which case, what do you do? Minimum, maximum, you make them the same.
In general, I generally don't fix the exact pressure, but I keep them on a range of at least 2-3, means 13 to 15.
So if your P95 is 11, which is the pressure you told us to look at for 2 years in a row, it's 11. What would you set it at?
I would set it 9 to 12.
9 to 12.
Yes.
That's
so why I'm saying it, so I have not shown it, but if you see overnight data of single light of an auto CPAP,
yes,
the P95 is 12. Or 11.
Right.
But most of the time pressure is 8, 7.
8,
most of the times pressure is below that.
So you keep it a little more lower than that.
So that your patient can have low pressure. When they require low pressure, they can be on a lower setting as well.
That's very useful.
No, so humidifier, I showed you the device. I think I'll just... So this is the humidifier on a device. This is connected on the side. It is filled with water. And it has a setting that how much humidification you want, what temperature do you want. You have to fill water in this. Like if you have seen ventilators have humidification. So that's what I was coming to. So a lot of devices were not coming with the humidifier. Now most devices come with the humidifier. If your patient is okay without a humidifier, no problem. But if your patient whom you have prescribed a device which does not have a humidifier and they are having problem of dryness of mouth, every time they have to wake up 2 times in the night. Yes, so if they complain, then you should either add on a humidifier to it. So depending upon which device you are using. Some devices have an option of add-on, or you can switch the device.
Yeah, I think you could, at the stall outside, ResMed, you could ask them about the humidifier. They have everything. They'll show it to you. I think one last question from Pushkar, because everyone's waiting for a cup of tea, Pushkar.
So, what ramp time will you adjust, and how do you adjust the EPR and the benefits of that?
Okay, so I have actually skipped the settings part because of the time. So ramp, everybody understands, ramp means the time the device will take to start to reach the pressure which you have set. Supposedly you have a patient whom you prescribe the pressure of 11 centimeters of water. So machine will take some time. When you start the device, it starts at 4, and when it starts, it reaches at 11 in some time. That time taken is called ramp time. So that time can be from 5 minutes, 0 minutes to 45 minutes in the device. Okay. So depending upon patient's comfort. So supposedly when I give a patient first time, I tend to give them a 15 to 30 minutes of ramp time. And if they are doing okay with that, I generally tend to reduce the ramp. रैम रिडक्शन इज ए गुड थिंग बिकॉज जितने देर में पेशेंट को रैम होता है ना उतनी देर पेशेंट अंडर ट्रीटेड रहता है. तो पेशेंट का प्रेशर 4 से बढ़ेगा, 45 मिनट में वो 10 पे पहुंचेगा. पेशेंट का रिक्वायरमेंट है 8 बट ही इज स्टिल ऑन 6. You understand? So generally with the time I tend to reduce their ramp. EPR is something which is not a very great setting. I would say EPR means you have a pressure relief at expiration. So I have not shown that setting. So EPR just helps some degree of exhalation for your patient. So I generally don't give them EPR. I generally don't give. If they complain a problem, I give them EPR of 1 to 2. High EPR has a problem because if you have very high EPR, what it will do is there will be a lot of variation in the pressure. So many patients feel discomfort when pressure is changing too much during the night. So EPR, either I switch it off or I keep it as 1.
Just one question, if you allow. You said the goal is to keep AHI below certain limit, maybe below 5 or whatever. But if the sleep is fragmented, even if you have good AHI, how do you know that if the patient is having fragmented sleep in spite of having good AHI? Is that should be our goal to have unfragmented sleep?
So as a physician, you tell me, how would you find out your patient's sleep is fragmented?
It will only on questioning. It will not be. I will not
Then
be able
it
to
comes from
prove
the
it.
patient's history. Patient will say, doctor, I am using the device, but still I am not sleeping well. So once your device shows everything is good, but your patient is not better, that means something problematic is happening. Whether it is central sleep apnea, whether it is fragmentation, whether it is arousal. Arousal device will not pick.
That's what. Will there be something in future that will pick up the actual quality of sleep also?
So there are a lot of home monitoring devices. Like if you have a patient who has a smartwatch, it will give them N1, N2, RAM. It will give you the scoring of sleep. So the question which you asked in the beginning, consumer technology. Consumer technology is going to be an add-on to what we do. So if I have a patient on a PAP therapy, doing fine, and he comes to me and brings his watch that my sleep score on the device is 60. What does it mean? So now I have to tell you what is sleep score. So that's a different topic, but if their sleep is poor, you may have to do a study on PAP. Okay, you apply them a PAP in the lab and do what is happening to them. So there's a lot of troubleshooting which needs to be done after initiation of PAP, and I think that's not the topic of today's.
But I think we could, we will continue this in the TVEC. So sorry, because we have so much ground to cover. We have enough time for questions as we go on. And Pratibha, thank you. We want to thank you.
Thank you so much for that lovely lecture. We're going to have a quick tea break of 10 minutes and we'll be back for the further
I
session.
think we can have 15 minutes tea break. Yeah, we have some sandwiches and tea.
Yes.
And do come. We have non-PAP therapies. We also have examination of the upper airway, and Kunal Banavli from our hospital will be there in the during the discussion to explain to you how to examine the upper airway. And then we have insomnia, which we have enough patients of, in this city at least. Thank you.
talked about PAP, we'll now be talking about management of obstructive sleep apnea beyond CPAP. So as we all know, I think the major challenge that these patients come up with once they've initiated on PAP therapy is compliance. It's a well-known fact that compliance of PAP therapy remains a challenge, not only in the short term but also long term. So people who've been successfully initiated after titration on PAP therapy may not actually have good compliance on follow-up. And hence we were talking about that we cannot just forget about these patients once we put them on PAP therapy. So of course the age-old conservative measures that we talk about, weight loss, definitely I think that has been the age-old prescription once we saw a patient with sleep apnea, please lose some weight. So we make a passing comment and we forget about it. Of course we do not counsel them about how to go about weight loss. So that's also something that we need to incorporate into our practice. Have them maybe meet a dietitian or a nutritionist, give them a plan, ask them to start exercising, because once they start using therapy, they will definitely be more alert, awake, feel more energy to be able to utilize their energy into exercising. Otherwise, these patients are so chronically sleep deprived that if they are not on therapy, they would find it a challenge to do anything in terms of physical activity. Alcohol cessation, I think like we were discussing, definitely something. Alcohol is known to worsen sleep apnea. So if a patient who's come to you has been having alcohol, then you obviously need to counsel him to stop alcohol, not only from the sleep apnea perspective, but of course other health effects as well. For somebody who is socially drinking, he's bound to have worse apneic episodes on the night that he consumes alcohol, so he should definitely be aware of it. And then he sometimes may actually become a candidate for not just a basic CPAP but a auto CPAP, because his pressure requirement is going to be variable, especially on nights that he's using alcohol. Positional therapy is another thing. We all talk about sleep apnea being much worse in supine position, and especially supine position, REM sleep in supine position. So there are people who actually have positional sleep apnea, that is their AHI is more than 2 times when they're lying in a particular position, more commonly supine. So if they have positional sleep apnea, they may not be good candidates for a basic CPAP. They might need a auto CPAP, and if they do not actually comply with the PAP therapy, then they may be candidates for positional therapy. So when we talk about positional therapy, the age-old therapy was swing tennis ball to the patient's pajamas so that he does not go on his back. However, there are now therapies which are like a small lead is attached to the patient's back. It is switched on when they are sleeping, and this just gives a vibration when the patient goes supine. But of course there is challenge with this kind of therapy, because every time that the positional therapy is vibrating or the patient goes supine and the tennis balls hurt him, his sleep is still getting disturbed. So this is actually not the ideal form of therapy, but for theory's sake we should know about it. We've discussed nasal decongestants, especially if the patient has any allergic tendencies. You must address those with nasal steroids or decongestants as per the patient's requirement. So now going back to weight loss. The age-old way of weight loss, very popular, especially in the glamour world, is definitely bariatric surgery. So a lot of patients would actually ask you if bariatric surgery is the answer. Well, definitely not. Many studies have actually shown that even though 10% reduction in weight does reduce a AHI by 26%, however, these procedures have risks of their own, definitely, and also that the weight loss is sometimes not really sustained for these patients, and it may actually not even be absolutely curative in terms of sleep apnea. So I was having a very good conversation with a dentist outside for dental devices. I'm sure they would know much more, and I also like to be enlightened. So there are various dental devices which are available, especially for people who are non-PAP compliant, for patients who have obvious retrognathia, For those people, dental devices are a better option. For patients with mild sleep apnea, where you may not want to give them PAP therapy, dental device is a great option. And patients even with moderate and sometimes carefully selected severe sleep apneics who are not compliant to PAP therapy, dental devices are a good option. But also for people who have severe sleep apnea and retrognathia, if you do not correct the retrognathia, they may not actually even respond to PAP therapy. So even with the PAP therapy, sometimes you have to use dental devices. I think I'm not wrong. I do, yeah. So, of course, there are a variety of methods which the dentist would know better, but when we talk about adults, there is a titrated tailor-made device, and then there is a boil and bite device which are available. They basically mechanically increase the pharyngeal dimension with varying degrees of success. They are usually titratable also, so they just are titrated by 1 millimeter. So the jaw is actually advanced. So it's not like you advance it on the first night itself. It is subsequently advanced to the proper position where not only the apneas are eliminated, but also the patient is comfortable. So again, this is also titrated and I have to be slowly titrated to be in the position. Of course, they are much cheaper and slightly easier to use than the CPAP, are to be used only when the patient is sleeping. Sometimes they do not have complete response. Sometimes these patients may need the CPAP with the therapy, but however, like I said, in mild to moderate cases, mandibular advancement devices are actually now shown to have very, very good response. This is how it usually looks. I think we'll have a discussion with the dentist on board and they'll be able to tell better. The American Academy also recommends mandibular advancement devices, and all sleep physicians are recommended to prescribe oral appliances rather than no therapy at all for adult patients who require treatment of primary snoring, like the dentist were pointing out. Then oral appliance therapy is prescribed by a sleep physician. Also, a qualified dentist has to be on board to titrate and to custom make these devices. And also the sleep physician should consider prescription of oral appliances rather than no treatment for adult patients who do not tolerate PAP therapy or prefer alternative therapies. So mandibular advancement devices, I think, are finding a major role in the therapy of sleep apnea. So mild to moderate, especially, or patients who are intolerant to CPAP, mandibular advancement devices must actually be given a try. And there are quite a few available in the market. All the dentists usually make it by themselves also. So I think there are lots of options, but always have a dentist on board. So identify a dentist who can actually help you out, and do always liaise with them when you get a complicated patient. So, of course, qualified dentist is a mandate, and these patients, of course, follow-up also should be in a close follow-up with the dentist with respect to their mandibular advancement devices or oral devices that they've been using. Sleep physician should also conduct a follow-up sleep testing to improve, to confirm the treatment efficacy if needed, especially if the patient is still symptomatic. And sleep physicians and qualified dentists should instruct adult patients treated with oral appliances for OSA to return for periodic office visits and not just use the device and be lost to follow-up. So any therapy in sleep apnea would actually need close follow-up. Of course, like I said, it has to be a gradual titration, otherwise the patient may actually complain of pain, excessive salivation, dry mouth, teeth discomfort, gingival irritation, masticatory muscle tenderness, and most importantly, TM joint discomfort. More severe and persistent side effects may be arthralgia, myofascial pain, teeth pain, and occlusal changes, but these all happen when the device is not right or not adequately titrated. Otherwise, it does not have any side effects and is usually very well tolerated by patients. Of course, coming to the surgical options, which I am only going to name because I am not an ENT, and I think this is where the ENTs are more apt to talk about. It may be used as a primary form of treatment, especially in select patients who have identifiable anatomical problems like maybe enlarged tonsils, especially enlarged adenoids in kids. So that's where the major role stands. However, it may also be used as salvage therapy, especially for patients who are non-compliant or non-tolerant to CPAP. So anybody who's non-tolerant to CPAP could actually be subjected to an upper airway and a dental examination, and depending on the level of obstruction or the anatomical obstruction that the patient has, can actually make a plan. And even if that does not clear the picture, you may want to refer this patient for a DISE, which is a drug-induced sleep endoscopy, to look for the level of obstruction and then decide a plan of management together as a multidisciplinary team rather than, have the patient run from pillar to post between doctors trying to figure out that what works best for him, at which point he may actually be lost at some point and may not take any treatment at all. The pre-surgical evaluation, like I said, would need not just upper airway examination, but sometimes even a DISE or a dynamic MRI may actually be needed for these patients to get clarity. The main objective of the surgery is to improve or eliminate the airway collapse that occurs during sleep while preserving the normal function of the upper airway and related structures such as obviously speech and swallowing. And when we talk about surgical success, literature actually defines surgical success as a reduction in AHI by 50% or less than 20. So when they talked about success in sleep surgeries, they were actually not talking about curing sleep apnea. It was only reducing the burden. So, but this is back then. I think now a lot has changed. They do multi-level studies. There are also dental surgeons doing a lot of jaw surgeries for these specific patients. So I think a lot has changed. However, surgery is still not the first choice. CPAP still remains the gold standard of treatment. These are all alternative treatments, and the patient selection has to be very, very carefully done because the wrong surgery, which is going to be maybe sometimes even multiple stages, take a long time, and the patient may actually not achieve cure. So you have to be extremely careful about selecting these patients. So look at the PSG data very carefully, make a specific plan for every patient, which usually I at least prefer has to be with a lot of communication between all the doctors who are involved, and then offer what is best for the patient rather than just hitting in the dark. And equally important is recognizing that not every patient will be a good surgical candidate because everybody's anatomy, physiology, and comorbidities are going to be different, and surgery should only be undertaken after comprehensive patient counseling has been done, and you must explain to the patient that even after everything has been done right, it may not be curative. It may actually just reduce the burden of his problem or make his pressure requirements less or make him maybe more compliant to the TAP therapy. Of course, various surgeries are available, whether it is polypectomy or ablation of turbinates, septoplasty, adenoidectomy, tonsillectomy, the UPPP, which is very famous, LAUP, then rapid maxillary expansions, midline glycectomy, tongue-based reduction surgery, mandibular advancement, genioglottal advancement, hyoid myotomy suspension, maxillomandibular advancement, and the age-old tracheostomy, which let's hope we would not need for any patient anymore. So these were all these treatments which are extremely invasive and that, of course, would scare any patient to undergo such massive surgeries for treatment of sleep apnea. The very much talked about newer treatment, new kid on the block is the hypoglossal nerve stimulation. So there are two systems which are available. One is the Inspire system, not yet available in India, but I think would be launched very soon in India. So this basically is a unilateral hypoglossal nerve stimulation, and it stiffens the muscles in and around the tongue region and keeps the airway open. So there is a small pacemaker which is surgically implanted and in the subcutaneous window, and the lead goes to the hypoglossal nerve. It is practically a OPD procedure done overseas. I don't know how they'll do it in India, maybe as a daycare procedure. And it has a remote. The patient actually switches on the remote at night and this gets into play, and that's how it works. So every time the patient has apnea, this activates, stiffens the tongue muscles and prevents airway collapse. Then there is the other one, which is not US FDA approved yet. It is approved in Europe, however, and not available in India, which is called Genio. So this is a small, this thing which is surgically implanted here in the neck and has a remote and a this thing outside. So this with the disposable strap is uh, put every day, every night on the neck, and the patient turns it on when he's going to sleep. So this is the Genio, which basically is bilateral hypoglossal nerve stimulation. So they both, of course, there are few studies which have showed the surgical site infections and everything for these two devices, but I do not think the incidence is very high. However, the most limiting factor, at least in the Indian scenario, would be the cost. So the Inspire system costed something like 50,000 US dollars. So I think in Indian rupees, it's probably going to be a lot of money, and I'm not sure how many patients would be willing to pay up that kind of money. But of course, that will very soon be an option for the Indian patients as well. So, and then there is this other thing in the market now, also available in India, which is the negative pressure device, which is the variant which is available in India now is the INAP. It basically, through a mouthpiece, the patient puts at night with this interface which is connected to the machine. This just creates a gentle vacuum to pull the tongue and the soft palate outside with gentle pressure. Again, the pressure here also is titratable. It has to be titrated about how much pressure the patient actually needs to keep the airway open during sleep. And this pressure basically, so this is very good for patients who have retropalatal or retroglossal collapse during sleep. For them, it's a good option. And then something which I think intrigues all of us quite a lot is the terzepatide. So we used to actually talk about all these machines, and now there is a magic pill which says it will cure sleep apnea. And what do patients need? I think the only thing they need is a pill that works, and that's about it. So all the equipment and everything they can keep on the side. So terzepatide has had very promising results, not just in terms of weight loss, but also in terms of reduction of AHI. I think in 24 they also published the results of the Surmount 4 trial, which also had promising results for these patients of sleep apnea. And so far actually says it works, is available in India, people are using it. I have a few patients who have been on terzepatide. The only challenge in India still is that it is not approved for obstructive sleep apnea. It is actually approved for diabetics who are obese for weight loss, but not really approved for obstructive sleep apnea. So I do not at least have these people coming to us yet. I think their main focus still is the endocrinologist. So I've had my endocrinologist friend put my patients who were obese, who had obstructive sleep apnea, on terzepatide, and they are actually doing well. In terms of long-term side effects, we do not know yet, but I guess so far the patients are doing well, and the safety studies did not have any concerning side effects. So to summarize, the surgical success rate for OS is variable, likely because it is not a simple disease. Each patient needs a tailor-made plan for their specific problem. With time, effectiveness may reduce due to the natural aging of the body and increase in tissue collapsibility. And CPAP still remains the gold standard of treatment. However, if the patient is non-compliant, not using any treatment, we must offer them other options to make their life better, and definitely have our ENT and dental colleagues also on board to help us with that. Thank you. So yes, ma'am, obstructive sleep apnea does occur in children. A lot of that could also be because of rhinotonsils, nasal obstruction, but also a lot of syndromes have sleep apnea. In children, it's more important to be recognized because it does lead to mental retardation, physical growth problems, memory problems and all of that. However, I do not actually practice pediatric sleep apnea. That's a completely different issue. And it's like I was discussing, so it's extremely helpful, especially to have a dentist and a ENT on board for a person for a child with sleep apnea, because sometimes it's just a dental issue and it's taken care of in their growing years. They actually may not have sleep apnea as adults. So it could be a complete cure for them rather than just, trying to treat them.
I just invite Kunal also to chair. Kunal Banavli is a dental surgeon with tremendous interest in sleep apnea. So we have questions that you all have for the dentist and for Shivani. Please go ahead.
Is it wise first to do an ENT visit instead of ordering a sleep study directly?
So that's not how I have been doing it, ma'am, actually, because if the patient has come to me, I do look for other comorbidities, because what happens more often in India is that we get the tip of the iceberg patients. So there are patients who are really suffering, who probably have moderate to severe to sometimes very severe sleep apnea. Sometimes we get these patients in acute respiratory failure. So, but however, we at least ourselves do a upper airway and airway examination is the least that we offer them, at least on the first visit. However, if they are not subsequently helped, then we do send them for an ENT evaluation and sometimes a dental evaluation. And I'll ask Dr. Saab if he would want to add anything on the pediatric sleep apnea bit, because I think they're more equipped to answer that.
Kunal, could you also tell us how you examine the upper respiratory tract? Because I know it's a very basic thing we learn in medicine, but I think in the way healthcare is evolved, there's so many tests that some basics we tend to forget. Please.
Yeah.
And what exactly dental issues should we look for? I mean,
Yeah,
in a child?
so the first thing that we look for in a dental evaluation is the soft palate. Okay, so we have to see according to the Malampati index that how are we scoring the soft palate. So if we see it is as class 3 and class 4, okay, we are surely seeing that there is an obstruction. So this is the first thing that we see. The second thing that you see is a high arch hard palate. It's because if the palate is high arched, okay, it's either use of too much of thumb sucking or pacifiers during the early ages. It causes a high arch palate. If the palate is high arched, there is constriction of the nasal passage, and hence this is a airflow problem. The third thing that you see is absence of teeth or completely worn off dentition. Now, if the teeth are absent or the dentition is completely worn off, the bite of the patient collapses. If the bite collapses, there is no space for the tongue to hold on to, and hence it falls back. So, there has to be a good room for the tongue to be there or the muscles to be there. And hence, this fall of the bite or the collapse of the bite is one of the reasons. The fourth reason is any form of mandibular underdevelopment. If retrognathing mandible is again one of the major reasons why the tongue does not have a space in the floor of the mouth or on the upper palate. So these are the things that we see as a dentist to evaluate whether the patient has basically snoring.
Yes, please, Priyam. Yeah, Priyam is a dentist again with interest in
What about
sleep
mouth
apnea.
breathers?
And
Is that a sign?
Yes,
you can get a
mouth
mic.
breathing, yes, but again, mouth breathing also has some clinical signs that
Pratibha,
we
can you
have
get the mic there?
gingival inflammation in the upper anteriors. So, when we evaluate a patient for mouth breathing, the first thing would be to take care of the mouth breathing. Okay, and that can happen because of orthodontic appliance. So, there are fixed or removable orthodontic appliance because of which we can take care of the mouth breathing. So once the mouth breathing is taken care of, then we go ahead with the snoring and the apnea.
So Priyam is a dentist with interest in sleep apnea again and has done a course. Priyam, please.
So, actually, some other things that you could look at would be the position of the tongue. and that's why the mouth breathing also happens. Position of the tongue, ideal position should be on the palate and not in the middle or on the floor. So what happens is if the tongue position is not correct, then when the patient is asleep, then the tongue tends to fall back into the airway and blocks the airway, which is also one of the common sites of obstruction. So it's very important to correct, firstly see where is the position, what is the rest position of the tongue for the patient, and then correct that.
How do you see the rest position of the tongue?
So, no. So actually, I just ask the patient when they are talking to me, what is the position of your tongue? Where is your tongue? Is it on the roof? Is it in the middle or is it down? The patient should not know what should be the right answer. So you have to ask the question first. And of course, if the palate is narrow or if there is a tongue tie, then there is a very high chance that the tongue position is lower and not on the palate. Yes, yes.
Without asking a leading, without giving any leads.
Yeah. There should not be.
That's right. Correct.
Is it Malampatti score that you're talking, or you ask the patient to tell where the tongue is?
Yeah, you ask the patient to tell you what is the rest position. As in the sense, right now, when I'm talking to you, and if you didn't know what is the ideal rest position of the tongue, you would be able to tell me where your tongue is.
Where means?
Is it on the palate, as in on the roof? Is it in the middle, or is it more closer to the floor?
When the mouth is closed.
When the mouth is closed.
Yes. And
so
of course, mouth breathing. For mouth breathing,
you would agree that the tongue should be on the palate.
Yes, that is the ideal position.
The ideal rest position.
Where the tongue should be suctioned on the palate and your teeth should be slightly touching, just about slightly touching, and the facial muscles are relaxed. That is the rest position.
So, do you also look at this, Kunal, and in terms of devices, and because you all prescribe devices, non-PAP devices?
Yeah, so regarding devices, there are, as doctor had mentioned, okay, there are 2-3 devices which are there. Okay, the mostly what I am doing into my practice and mostly what I know people are doing in the practice is comes with an elastic mandibular advancement. Okay, it's known as a EMA device. It's very easy to fabricate. The upper and the lower scan or the impression is taken. We have a particular George gauge for measuring it. What we do is it has a movement in which you can fully move your mandible in the front as much as you can. So we mark the point there. Then we mark the point where the normal bite is. And exactly the center of this two, the upper and the lower cast of the patient is mounted and sent to the lab. So the lab makes a upper aligner, a lower aligner, and depending upon that position, the lab gives us a elastic. Now these elastics which are there, they come into particular sizes, starting from 20 to 24. So depending on that position, they give that rubber elastics to us. And then we place it in the patient's mouth. So the upper and the lower aligner which is there is attached with that rubber bat. So that is the mandibular advancement device.
I think
the patient compliance for the EMA is much better than an orthodontic appliance which requires you to use a screw to titrate it. Because yes, absolutely. Because see, what happens is initially it's very difficult for them to understand that there are two aligners in the mouth attached. Their mouth is not fully opening. So what we do is we tell them to wear it for half an hour to 45 minutes in the morning or evening time when they are watching TV, reading a newspaper, just for them to understand that how it is going to feel in their mouth. And once 4-5 days have gone by, from the 6th day, we start telling them to wear it at night. Those appliances charge somewhere around 30,000 rupees.
Can I ask one question? What is the role of airway orthodontic treatment? Like it is a kind of a permanent repositioning of the jaw or even the nasal space which is crowded, especially in children. So are you recommending airway orthodontic treatment?
Yes. So the thing is that, as I said earlier, that the shape of the mandible, whether it is constricted, whether there is malocclusion, whether there is crowding of teeth, okay, they are the first things that need to be treated, because the tongue constriction or the space that the tongue doesn't have, the musculature problem, is all because the dentition is not in the right space, or the development of the jaw has not taken place rightly. So if, when it comes to, as doctor mentioned, pediatrics, okay, if the kids orthodontic treatment is done properly at the proper age, when there is crowding, when there is teeth issues, we are looking at an adult who might have a very less chances of developing these problems, because most of them are anatomic problems.
Sir, in studies, it has shown that it does reduce AHI. Mostly, I would feel because of the reduction of weight, but at least US FDA has approved it for both
I think what
indications,
is
weight
trying to ask
reduction
that
and sleep
if it is used in non-obese sleep apneas, will it work?
So,
That's what I believe.
sir, that's difficult to answer because the studies actually had a BMI criteria. So it was used only in obese adults, so that's going to be difficult to answer currently.
So this is going to be an interesting.
Coming on the same lines, if a non-obese is sleep apneic, so how would you identify the cause first? Because the treatment, we are just managing the treatment. We are not looking for the cause. For example, how do we avoid it in upcoming population or identify who are high risk sleep apneics? So if we remove the obesity part, what would be the criteria?
See, I think we do see a lot of non-obese and even people who are, in the younger age group who have sleep apnea. So non-obese, I said non-obese. So definitely we do see. I think maybe it would be interesting to see their dental makeup and the upper airway obstruction per se, rather than just focusing on the sleep apnea. Definitely.
So this is obstructive sleep apnea. So there has to be an obstruction somewhere. So whether it is a obese or non-obese, there has to be an obstruction. Right. So obese is, there is the role of the ENT. By the way, I am an ENT.
Yeah.
So an ENT has to look at all obstructive sleep apnea. It doesn't make any sense to not look, because some of the obstructions can be corrected.
Correct.
True that in spite of that, with age again the patient may, but those are different causes. Those are muscle collapse, fat deposit and all that. There is where bariatric surgery and the drugs help, because they are just reducing weight. And that's the first line of treatment which we tell patients, that you reduce weight and improve your tone. Both the things are required. Not just reducing weight, you also have to improve both your oral muscle tone as well as your external neck muscle tone. There was one more question I wanted to ask, was this, there are ready-made devices available for this thing. What is your take on that and what is your experience with it?
I have not used it, and to be
Why?
very honest, not a good idea to prescribe them. The reason is because, as I said, that the fabrication of this device, okay, is completely dependent on how much your jaw moves forward and how much it is in normal position. When we mark these two positions, the elastic which the appliance is fitted on depends upon where exactly the center lies. So when it is not customized for a patient, either the jaw is not going to move forward and hence the epiglottis is not going to be avoid falling back, or it's going to move so much forward that the patient is going to start having TMJ disorders, which is retrodiscitis.
But it is approved abroad.
Approved, I don't know whether it has an FDA approval or no,
I
but
think it has
this
the CE
Snore
approval
Plus
is surely there. It's
device
a
which I'm talking about, or any EMA which I'm talking about, they are surely FDA approved.
Can I add something?
We will
Also,
have
there's a
to,
word of caution. What happens with these, either surgery or with the devices, is that your snoring may come down. but it doesn't mean that your sleep apnea has got
Apnea
completely corrected.
correct.
Yeah,
So you should be doing a study to see whether there is
Yes.
complete correction of the sleep apnea, which a lot of times I see doesn't happen. So I think that is a
So
word of
after the
caution.
appliance is given, okay, usually we tell the patient to undergo the sleep study again, either a sleep study or a split study, to know what was first and what is after the appliance.
Thank you. Thank you, Kunal, Shiva. I mean, I know there are a lot of questions, but we have them here till lunch. Don't worry. And thank you, Kunal. Thank you, Shivani. And I'll invite Saurabh because there's a lot of questions on the upper airway, and I'm glad we have an ENT surgeon in the audience who can also help us with some of those tricky areas. Saurabh's going to talk on the examination of the upper airway, and of course other issues that we have related to this. Priyam, you wanted to make a point? You were saying something?
giving the mic back. But actually, what I wanted to say is there are lots of studies actually done abroad which shows that a customized mandibular advancement device is more comfortable for the patient, and our treatment relies on compliance. And that's why a lot of times CPAP fails because the patient is not compliant. And boil and bite, if you see, they are quite they're quite bulky. So in addition to the issue with TMJ, of course, so the titration is not very smooth for the patient, and also they are quite bulky. More the bulk in the mouth, the less comfortable it is.
Thank you.
So, so continuing on the same part, I would just add one point to the discussion that all these non-PAP therapies, whenever employed, they need a follow-up study. So because on PAP we get data from the machine that what is happening to HI, what is happening to the patient, but with none of these devices give out a data at the end of it that how they have functioned. So generally at 3 to 6 months of usage of any of these therapies, you need to perform a sleep study and see whether it's a surgery, upper airway, mandibular advancement devices or anything, weight reduction therapies, you need to perform a repeat study to look at the evolution of disease and resolution. So that is one part I wanted to talk. Now next is examination of upper airway and when you should refer to a sleep specialist. So this is completely not my domain. Some of it is dentist domain, some of it is ENT's domain, and some of it is what we do. But I have brought kind of things which anyone should do, right? Not so there are some things which an ENT person would do. I have brought them from an ENT colleague of mine. So, but the purpose of this discussion is primarily how do you evaluate a patient of obstructive sleep apnea in a general physician's practice, right? Okay. So, why are we discussing this problem? Because this is very common. So, I just wanted to bring this point. Probably it has not come till now that how common sleep apnea is. And it is associated with a lot of medical problems we all understand, but we probably don't recognize. And it is associated with a lot of poor clinical outcomes. So, it is extremely important for the general physicians to recognize obstructive sleep apnea in their practice and do an evaluation and a referral in time to prevent the complications. So how common it is, this was a meta-analysis which was published and we found that almost 11% of population had. Now there is data from other parts of the country which show 30% prevalence. So I would say think that everybody who comes to you, I tend to ask whether he has sleep apnea. Okay, I tend to think in that sense. So I would ask everyone, how many of you think you have sleep apnea? Don't answer, but just think that how many of you think that you may have sleep apnea? How many of you think that your parents may have sleep apnea? How many of you think that your children may have sleep apnea? So this is something which we are missing in our family, our practice, our neighborhood, our patient group, because we are not thinking of it. I would say if we take a prevalence of even 20%, that means 20% people sitting here might have sleep apnea. You understand that? So it is important because the problem is that we don't think and we don't recognize. So now I'm going to tell you when should you think that patient may have a sleep apnea. So I think so as a clinicians, we need to ask for some history, do some examination. We need to perform an ENT examination as well, whether it is done by an ENT specialist or by a general physician. We need to perform a polysomnography or any kind of sleep study. Sometimes they may need a drug-induced sleep endoscopy by an ENT surgeon. And then eventually we need to take a decision, how are we going to manage the patient. So this is the workflow for a patient who comes to a clinic should be done. So what are the presenting symptoms? So how many of you think that sleep apneics have problems? Everybody? Yes. So there are certain symptoms which are nighttime symptoms, and generally patient brings them: non-refreshing sleep, disturbing snoring for their partner. The partner has noted that their breathing stops in between. Sometimes they make sounds during the sleep, gasping sounds, or sometimes patient has to wake up suffocating in the night. They may have nocturia and they may have a nocturnal sweating. So nocturnal sweating tells me that it is sympathetic activation in the night because of hypoxia. So these are some of the nighttime symptoms the patient or the spouse will complain of. There are certain daytime symptoms: tiredness, daytime sleepiness, memory impairment, very common. I would see, if you see somebody who is having memory impairment at 40, 45, 50, think of sleep apnea. I'm telling you, this is not uncommon. You'll find a patient who comes to doctor, I am feeling that I'm forgetting things. And once you take their history, they have been sleep apneic for 20 years. Irritability, mood disturbances, depression, erectile dysfunction, headache. So these are some of the common symptoms patients may have, right? Now the problem is that a lot of sleep apneics may not be symptomatic. And this is a major chunk. Almost to 1/3 of patients may not have significant symptoms to be brought to the clinician. The only symptom which everybody should have is snoring. So sleep apnea has to have snoring. Sleep apnea, obstructive sleep apnea cannot happen without snoring. So everybody has snoring. So the point should start from the snoring. Do you snore? Yes, no. If you don't, your partner does not complain snoring, you are out. You understand? So that works as a kind of the most basic screening question. But in Indian setup or in other settings, a lot of times patients would deny. But if you still think, you ask them, okay, ask your partner to make a video of yours while you are sleeping and bring it to me. So some of the things can be done even if you think the patient has sleep apnea but patient denies the symptoms. So there are certain screening questionnaires which can be used in clinical practice. So they are not very good, but there are some. So this is one of those which we tend to use a lot because it is something that we have to use something to kind of find our patients. So this is called stop bang questionnaire. So stop bang means it has 8 points. Stop means as for snoring. Sorry, I'll just get the pointer here. Okay, so as for snoring, that means you have a loud snoring. Do you feel tired? Has anyone observed that your breathing stops in the night? Or do you have high blood pressure? So these are the 4 questions. If you have yes, that means 1 point is given to each. And then you have bang part of it, that is BMI more than 35, age more than 50, neck circumference more than 17, and gender if you are a male. So this questionnaire, what it does is that it kind of classifies a significant proportion as high risk, and those can actually be taken up for sleep study. Now, let me be very clear to you, because you use this in your clinical practice, this will miss a lot of patients. So this tend to pick up only the very high risk of individuals. So if you have 100 sleep apneics, this would probably pick up 60% of them. 40% will still be missed. So this is not a gold standard test, gold standard screening. It's a poor screening tool, but it is still a screening tool to identify some of your patients. So even if you learn to use it, your pickup rate would increase what you are doing currently. Also, there's something called as enhanced stop bang. So if you have stop, that means 2 of these features, but you have a male or obese or a high thick neck individual, you are likely to have OSA, and then you can kind of take them for a sleep study, right? So this is not a very good tool, but it's still a okay tool to be used in clinical practice, specifically for a general physician. There are other questionnaires like modified Burling. There are certain questions. So this depends upon which practice you are in, how much time do you spend with your patient, and you can use the questionnaires. What is important is a sleepiness assessment. Okay, so we all talk about excessive daytime sleepiness, excessive daytime sleepiness. So there is something questionnaires called ESS or Epworth Sleepiness Scale, which we use in sleep clinic. May not be useful in a very general practice, but you should know these questions. So you may not give them an exact score if in your clinic, but these are 8 situations and how likely the patient is likely to fall asleep. And if your patient sees that in these situations they tend to fall asleep, that means even if you don't give them a exact calculated score, it turns your mind on that this patient may have sleep apnea. So there are certain scales which are kind of validated for identifying sleepiness. Okay, so this is about the history taking. Now we talk about what are the consequences. This is also very important for general physicians to know, understand, and communicate it to your patients. That what are the problems that can happen? They can have hypertension, diabetes, obesity, GERD, pulmonary hypertension, impotence, nocturia. You name it, and it is there. Why it is there? Because sleep is the position in which we spend one third of our life. If that one third part of our life is not well, we are going to end up in a lot of complications. So that is why it is extremely important that we kind of educate our patients about good sleep and identify their sleep problems in time. So this slide is also very important. I made it specifically for the physicians. So there are a lot of medical disorders which are associated with sleep apnea: bronchial asthma, allergic rhinitis, COPD, hypoventilation, diabetes, CKD, prediabetes, hypertension, arrhythmia, heart failure, stroke. So if you see these patients, think that they may have sleep apnea. Yes? So if you think, you will find. If you don't think, you will never find. Now we talk about the examination part of it. So examination part of it is, one is obesity. Look for obesity. So this is also important to understand that obesity cutoff is, what is obesity cutoff? Can anyone tell me what is obesity? In your practice, what do you think is obesity? 25. Okay, very good. At least we are below 30. So now the obesity cutoffs has gone to 23. Okay, so the Indian guidelines say that now anybody who is above 23 is class 1 obesity. So this is important to understand. What we think obesity is beyond obesity. If we think as more than 30, they have gone beyond obesity. So it is extremely important when we think of obesity in our clinical practice, it is much lower. You understand? So think, okay, if you take it 25, it is still acceptable to me, but you should not take it as 30. Now when patient is waiting for you to see in the clinic, if you see in your CCTV that patient is sleeping outside, you know that they are excessively sleeping. If they are snoring outside, they are yawning outside, then you know they are sleeping. Then you can do some dental examination and the ENT examination, which I will come to. Very basic Malampati examination. So you ask them to open their mouth and you see what you see. If you don't see anything, they have a crowded upper airway. I think that's the best word I use for my patients. I'm not an ENT surgeon, I'm not a dentist, that they have a crowded upper airway and we need to do something about it. So airway caliber assessment is very important in general practice. So you can have a X-ray, you can have a NCCT, whatever way an ENT person does it, but there are a lot of places. So let me tell you, when we were talking about the why, Dr. Saab asked, why does OSA occur? Okay, it's anatomical, but it is not only anatomical. So that means problem starts from here, it ends here. So there's a problem from here till here. It is anatomical, but even if you clear the anatomy, it's not sure that when you have cleared the problem, because there is muscle problem, there is arousal problems in the brain, there are control problems in the brain. So sleep apnea is not only anatomical. Anatomy is essential to be there, but other things compound that problem. So even if you clear the anatomy, you clear everything, you may still have OSA because your muscles are not functioning well. Okay, your brain is having arousal thresholds which are low. So you need to have a thinking that obstructive sleep apnea is not purely anatomical. It has other components as well. So when we are talking about examinations, we look for DNS, polyps, adenoids, tonsils, jaw, whether it's small or whether it is retrographia. And sometimes ENT surgeons do examination for dynamic airway obstruction, which I'll show. So some common findings you can find on tonsil, uvula. I'll show some of these. So you have something called as long face syndrome. If you see patients like this, long face, they have a low tongue position, they have a lip bite, mandibular drop. These children, maxillary hypoplasia, they are likely to have OSA. You can examine the nose, very easy to examine. If you see there is nasal wall narrowing, that is there is a nasal obstruction happening. Convex face profile. This is very easy to identify. Probably dentists would understand it more. So if you look at your patient from your side, if you have a convex face profile, that means their mandible is either small or it is retrognathic. So that means they are at higher risk of development of obstructive sleep apnea. You can have tongue tie, you can have high arched palate, you have a enlarged uvula, large tonsils, bifid uvula. So you can have a lot of things which you can see in your clinical practice. You don't really need an ENT surgeon to at least tell you. So if I see a patient of sleep apnea, I examine, I find this, I send them to ENT that okay, please remove this so that I can do further evaluation of my patients. So rhinoscopy is done generally by ENT. So you can have patients who have clean nose or those who have allergic rhinitis, they can have very congested nasal mucosa on days. You can see nasal polyps sometimes if you are doing rhinoscopy, or you just do a light examination also. So you can find the adenoids also on examination if you do, it is done by an ENT surgeon for the rhinoscopy. Now a word about the DICE. So DICE is something which ENT surgeons do. Okay. So what is DICE? So what I have told you, that I have examined the patient in a sitting position. Okay. I have examined their upper airway while they were awake and sitting. Now I don't know what happens to their airway when they sleep. And that's what I'm interested in. So that is why what they do, they give a drug to the patient sleeps in the OT, and they do an endoscopy and see where the problem is. When patient starts snoring, where the obstruction is. So that's called DICE. Generally, DICE is reserved for individuals where you think that you are planning a surgery, where you have done a sleep apnea evaluation, you have found that they have sleep apnea. Now you are planning that they may benefit from a surgery. You do a DICE, you find out where the obstruction is, and then you treat those patients. So just very easy to tell you. So when we are talked about from nose to the larynx, so there are 4 points which are seen in a sleep endoscopy. One is the velum, oropharynx, tongue, and epiglottis. So during DICE, an ENT surgeon looks at these 4 points, what is the degree of obstruction and what is the type of obstruction, and that's how they tend to decide treatment for surgery. So whether they need to work here, whether they need to work here, or whether they need to work here. So DICE is generally reserved for patients who are planning to undergo a surgery. So when you send a patient to an ENT surgeon, okay, this patient of OSA is not willing for a CPAP, I want them a surgery. So they generally would do a DICE before doing up a definite surgery. One important thing, the examination which I have told you can be done by a physician. In general, in our practice, all sleep apneics who are diagnosed, they go to an ENT surgeon for an examination. So they just examine, tell me, okay, they have grade 2 tonsils, they have this polyp, if you want, I can remove them. Okay, so that means you can open up the anatomical airway before you start them on a PAP therapy to improve their comfort of PAP therapy. So this is something which would vary from center to center, but I would still feel that ENT surgeons should be on board for first evaluation of all sleep apnea patients. So I'll skip the videos of the, I think, DICE. I brought some of them. One is Muller's maneuver. So when I was talking about the examination of upper airway, so I was doing it static examination. Now there is something called as Muller's maneuver. That means patient is asked to collapse their airway. So once with that, the endoscopist can see what is happening to their airway. So this is the resting airway, and during the Muller's, it constricts. So they can find out on Muller's maneuver what is the site of obstruction. So Muller's is generally done in outdoor, and DICE is done while the patient is in OT. So these are some of the things which ENT surgeons do for evaluation of their sleep apneics. Some of these can be done by a physician, some of them have to be done by an ENT surgeon. So what are the other investigations we generally do for our patients? In all, blood sugars, they are at high risk of dyslipidemia, thyroid. So TSH generally we tend to do before sleep study. So a patient comes to me, I think they may have sleep apnea, I get a TSH before I send them for a sleep study. Because if they are hypothyroid, I treat them, they would lose weight, they would lose their fluid, their sleep apnea would get better. So I make them euthyroid and then do a sleep study, right? Look for fatty liver disease. This is very big killer in our times now because there is insulin resistance in these patients and they would die of, a lot of them would die of NASH. And a routine blood examination for kidney function, liver function. So this is something which we do for most of our patients. Now the question, when you should order a sleep study. So there is no 100% answer to this question. Okay. So I would suggest that you see patient as a whole rather than looking at one question, one screening questionnaire or one disease. These questionnaires I have talked about, they can be used, but they are not very good screening tool. Even if the patient is stopping negative, they may still have significant sleep apnea. So sleepiness and fatigue, it is also very important in clinical practice. You ask your patient whether they are fatigued or whether they are sleepy. So those are two different things. When they are sleepy, you think of sleep apnea. If they are fatigued, you may have to think of endocrinal disorders and other things which may cause fatigue rather than sleepiness. Obesity and snoring. These are, in my practice, I find these are the two very good screening questionnaire. If patient snores, I can move forward. If patient is obese, I move forward for further evaluation. If they have hypertension, you think of sleep apnea. They have arrhythmias, think of sleep apnea. they have cardiovascular disease, CAD, they have CKD, think of sleep apnea. They have chronic respiratory disorders which are uncontrolled or resistant to treatment. Severe asthma, severe COPD. They have chronic neuromuscular disorders. Think of sleep apnea as a comorbidity. So this is not an extensive list, but this is a list for a general physician to think that if you see any of these, think of sleep apnea and plan a further evaluation. And if your patient agrees, send them to a sleep physician for a study, ENT surgeon for ENT examination. That's where the things would move forward. So just to conclude, so high clinical suspicion is key to early diagnosis, I say. Snoring, tiredness, obesity, and upper airway symptoms should prompt a clinician to evaluate for sleep apnea. Uncontrolled comorbidities such as hypertension, which is resistant to 2-3 drugs, think of obstructive sleep apnea, very common. And upper airway evaluation remains a key investigation for further treatment planning. Thank you. Is snoring also harmful? Okay. So you have a patient who comes to you with snoring. You think patient has sleep apnea. You got a sleep study then. Sleep study shows no OSA. AHI is 2. Okay. Now, this patient, you need to tell him whether it is harmful. That's the question is, right? So that means once you have excluded significant obstructive sleep apnea, even then snoring has its own problems. One is obviously marital problems, social problems which happen. Somebody who is snoring on a flight and creating a problem for others. Number 2, snoring itself is associated with atherosclerosis. So it is proven that people who snore but do not have obstructive sleep apnea have accelerated atherosclerosis of their carotids. It is proven. So pure snoring is not harmless. Pure snoring is not harmless. Snoring is acceptable if it is less than 2-3 times a week. If it is more than 2 times per week, night, this is going to create problems. So that means it does not mean you do a sleep study, patient comes to you, doctor, I have snoring. You did a study, AHI is 4. You tell, no, you don't have anything, forget it. You still send them to an ENT surgeon, look for a cause, look for an obstruction, is there something which can treat their snoring, right?
So would you treat, the question is, would you treat snoring with CPAP?
No. No, I not said CPAP. Okay.
Why not a CPAP?
So why not a CPAP? Why not a CPAP is because this snoring itself alone is not as harmful as obstructive sleep apnea 1. So I would still want that it's an upper airway problem. I would always want an ENT surgeon to look at the problem. If there is something which is treatable by a surgery, it is always better idea to treat snoring by a non-CPAP method. If that is not treatable, patient says, no, doctor, my wife is not letting me sleep in the same room. You give them a CPAP of 4 or 5. They would do fine. Yes.
So the patient would be flipped back to you to look for any ENT problem. Your name is doctor? Nalini, that's nice.
It's not a cure. Okay.
The hypoglossal nerve stimulator, pacemaker.
Okay, so let me come to you. You have a diabetic, you start them on OHA, it's not a cure. It's not a cure for their disease. Similarly, you have a patient of OSA, you start them on a CPAP, it's not a cure. It controls the disease, it treats the symptoms, but it does not take away. You withdraw the OHA, sugar will go high. You withdraw the CPAP, OSA will come back. Okay, so that is one. It's not a cure for the disease, it's a treatment for the disease. Okay, now you talk about the hypoglossal nerve stimulation. So the response to hypoglossal nerve stimulation is very variable to a patient population. The trials have shown that it works well, but it does not cure the disease. Let me come to you. You have a patient who has AHI of 40. The AHI may come down to 15 with the use of hypoglossal, which is good. For a surgical candidate, it is good. It may not be a cure for disease, but it becomes easy for the patient. You understand? The problem with the entire sleep community is CPAP. How can I avoid CPAP? You understand? The entire research is going, how can I avoid CPAP? And because I am a kind of proponent for a CPAP, I would say that if you have a patient of asthma, you take 100 asthmatics, how many of using inhalers regularly? 40%. Same is for CPAP. If you have diabetics, how many of taking their OHAs regularly? 50%. Studies have shown that. So that means it's not the problem of just CPAP, it's a problem of the patient and doctor communication. You tell them right, they would do right. So you need to improve patient education and understanding, then only things can improve. Yes, ma'am.
My question to you and Dr. Shivani is, in your practice, how often do you refer your patients to mental health consultants and to relationship counselors because of sleep disturbance? Because it's an eclectic group of doctors and general physicians, and how important is it to recognize these two issues in sleep practice?
Okay, so I have never sent to a relationship counselor ever. So that's my honest submission. But for the mental health evaluation, yes. So why I would say that I have shown depression is one comorbidity, but it is not uncommon. It is very, very common. You talk to these patients for 5 minutes, they would bring 10 problems to your head rather than sleep apnea. So they are suffering from a lot of depressive disorders. So I would say in my clinic, at least 20 to 30% patients are under a psychiatrist follow-up as well. So, and they tend to, treat them for their depression, their OCD, whatever else they are suffering from. But psychiatric comorbidities are very common in these patients.
In fact, what I have seen that the psychiatrists have started referring patients now to the sleep specialists. In fact, psychiatrists in fact have started, which is an important change. As far as hypertension is concerned, I just wanted to have one clarification. At what stage of hypertension we should really be doing study? Is it at a resistant hypertension stage, or is it at pre-hypertension stage?
So resistant hypertension, 100%. Look, I'm not saying do a sleep study. What I'm trying to tell you is that think of sleep apnea.
Why not do at pre-hypertension? Why wait till the hypertension becomes resistant with two drugs and three drugs?
So if you do a test, so if I ask do the study of everybody, no, that's not the right choice. You choose a correct group, so you have a high probability.
How will you choose?
Probability of, no, that's the question. That's what I'm saying. You cannot do for the entire population. You have to select your patients. That is why I have given you those clues.
Entire hypertensive population, I still would try to, at least in my experience as a physician, MD medicine.
So you screen your hypertension.
Would like to screen rather than waiting with drugs for them to become resistant, because most of the hypertension we actually label them as idiopathic. And when it is idiopathic, there is one big group of, I think, sleep apnea which we are missing.
Yes, exactly.
So if we don't do the test, we will never actually pick it up.
So I would say that, hypertension in a 50 plus individual, when I see young hypertension less than 45, everybody, I would ask question and I would kind of push them that get a sleep study. If it's normal, not a problem for me. So for young hypertensive, 100%.
So as you summarize that, Pushkar, young hypertensives, risk factors, high stop band, I think those.
Yeah, that's what I'm saying. Not focus on one point.
You're getting many
see patient as whole.
Features.
If you have given one drug, patient is fine. You don't need to do much.
Everyone
If you see a lot of
yes. We do blood tests and we do health checkups. Mike. This side, right side. Yeah, sorry. So as we are doing so many health checkups, we keep doing their 2D echoes and stress tests as a part of health checkup also. I feel, in fact, as the prevalence of sleep study is so common in the population, in fact, it can become a part of a health checkup also at some point. Okay, yeah, thanks. Pushkar, thanks for the point. No, sleep studies are happening at home. The hospital can organize it at home.
Necessary. Actually, there are hospitals which are outsourcing and doing home sleep studies as part of health checkup.
But it's a very interesting point which I put across to Saurabh. Nalini, 1 second. Pushkar, 1 second. Health checkup. Now we see health checkup reports. 30% of them are not even necessary to be done. We know that. Would this be useful as part of health checkups?
For routine screening, I would say no. So why I'm saying no? Because, when health checkups or screening tests come in the market, they tend to pick up the diseased population. One. Number two, if you find a diseased population, can you do something about it? If in my health checkup, I do HbA1c, fasting sugar, lipid profile, thyroid, okay. I find any of these, I would take an action and do that. Sure. Okay. If I pick up an asymptomatic sleep apnea, which is totally fine and not listening to me, there is no point in doing a study. So let me be very clear to you when you are saying that sleep studies are so easily available. Convince a patient for a sleep study. We have a discussion on that. So convincing a patient for a sleep study, I would say if you tell it to 10 patients who need it, 5 would undergo it.
I think that's because sleep studies are not common as yet. Yeah. If people, after 10 years, I think people will actually do sleep studies.
I would 100% agree to the point. Once it becomes cheaper, more easily available, easily interpretable. if we have a device which can be sent to patient's home, I do now do the bring devices, you give them to the patient, no problem. Patient pays 3,000, 4,000 rupees, gets it done, brings me the report. So the simplification of sleep medicine would improve its applicability to the general population.
I agree. In fact, what Pushkar is saying, that a lot of these health checkups pick up things when things are already advanced. A CT coronary is being done in health checkups. So once you see coronary artery disease, it's much later. I think you're looking at it from a primary prevention.
So I think
point
what would be good idea in that sense, somebody employs it and finds out the positivity rate and the treatment outcome.
And still,
so then it should become part of
problem
our
is that many specialists who should be actually ordering sleep studies are not ordering sleep studies. That is a big problem that we are facing. Like coronary artery disease. How many of your bypass patients are actually undergone a sleep study? You're right, absolutely
stroke
right.
patients.
So that is a big problem that even in ophthalmology there is a role, like glaucomas can have sleep apnea.
Sure.
PCOS can have sleep apnea. Yes. Pregnancy hypertension can have sleep apnea. And all those specialists are not ordering sleep study. That is the reality of the world right
That's why
now.
this program is there to improve
So
the awareness.
we have more programs. We have 3 more questions. Rajam, this gentleman behind Pushkar in the last row. And then we have to go to the next talk.
Yeah, so when we are talking about sleep study so much, I really appreciate that. But nowadays we have these high resolution pulse oximeters, which can be put up on the wrist and the finger. And if those high resolution pulse oximeters, which are so comfortable and non-invasive at all, so if those show a lot of oxygen desaturation, then we can go to the home sleep test or a complete
So that's the
polysomnography.
simplest. We discussed that in the earlier in the morning. Pulse overnight oximetry could sort out your, but it's too basic with the current infrastructure we have. Yeah, Raj.
Yes, yes. So screening health checkup should include a medical consultation, in which you can ask for it.
Sure. Sir, the last row. Yes, of course, Shivan.
And so you made a sorry. And you made a point about PCOS having, so actually even infertility, and it's very interesting because the way we look at sleep apnea is very different in women, because there may not be actually so much obstructive events. There would be more hypoapneas, there would be more respiratory event related arousals, which are things we might actually miss if we are only doing a level 3. So that is also, and women may not present as snoring, excessive data. They might actually present with body aches, depression, those things. So that's also one thing that we should keep in mind.
The last row, before I.
Sir, my question.
So like I think Dr. Saurabh discussed the questionnaires, ma'am, but then of course they do not have 100% sensitivity or specificity. But yes, they are quite useful in at least screening patients.
The last row. Yeah.
Sir, my question is, oxygen therapy clinic is now running for sleep apnea and yoga.
Oxygen therapy.
Oxygen therapy for sleep apnea, no. Oxygen therapy is a big no for sleep apnea alone. Yoga, yes. So there is evidence which shows that yoga leads to improvement in quality of life of patients with sleep apnea. It does not cure sleep apnea. It improves the quality of life of patients with sleep apnea, which I would agree. We have done a lot of research in yoga in AIMS also in different diseases. So yoga works like sleep. I would say you improve sleep, you improve a lot of diseases. Yoga works on a complete holistic approach to an individual rather than one disease. So yoga improves the quality of life but does not cure sleep apnea.
I think
I
we
would
can
not be the
catch
best
these.
person for that. Sorry.
Saurabh will take these in the second tea break. We need to finish our last didactic. Thank you so much, Saurabh. Round of applause for Saurabh and both his talks. I'll call Prakhar, my colleague from Bombay Hospital and who's also at the Breach Candy Hospital in Mumbai. Outstanding psychiatrist, trained in the UK and has come back. And Prakhar is going to talk to us about a topic which is very common in our practices. Whichever specialist I think here sees an insomnic patient. So Prakhar, some basics for the physician here. Thank you.
Good morning, everyone. Uh, After a nice academic discussion about medical causes of sleep problems, we are now heading towards psychological causes, and it's an interesting thing to discuss. So, I'll first say that insomnia and sleep disturbance are different things. Insomnia as a disorder is has a prevalence of 10%. Sleep disturbance has a prevalence of more than 40 to 50%. So, insomnia is used in people who have sleep disturbance, but insomnia is a different disorder altogether in its own. Now, when do we call that someone is having insomnia? So, the primary thing is it is difficulty in initiation of sleep, maintenance of sleep, or early morning awakening. It will also be important to note that the person has had adequate opportunities to sleep. He is not overworked or he doesn't have a good environment to sleep. It's also important to note that this sleep problem should have caused a significant impairment or distress in his life. We can find people like our honorable Prime Minister who would have a sleep timing of much less than 6 hours. But he will not satisfy probably the last part, clinically significant distress. So it is an important aspect to look at. Now talking about the classification, so the basic is now divided into acute and chronic as per the time of the sleep trouble. Acute would be less than 3 months and chronic would be more than 3 months and having a problem more than 3 nights every week. So then we will call it as a chronic insomnia. Then as per the onset of the problems, during sleep onset, it is difficulty in initiation, sleep maintenance, that is frequent awakenings, and that early morning awakening, which is wakes too early or maybe doesn't feel fresh after waking up. Coming to the common causes and prevalence, so these are the common causes of sleep problems. It's not the common causes of insomnia disorder. So now we come about anxiety and depression, which accounts for 40 to 50% of sleep related troubles. The depression and anxiety is a vaguely used term here. It could also include PTSD, bipolar disorder, schizophrenia, eating disorders. So all of the psychiatric disorders account for around 40 to 50% of patients who would have complained of sleep problems. The other important aspect is the chronic pain related to fibromyalgia, arthritis, chronic diseases, ulcers, GERD. Then the sleep apnea, of course, a prevalence of 15 to 20%. And in India, like we heard, around 30% also have been found sleep apnea. Very important and often missed during discussion or a history taking is substance and caffeine related, which accounts for a significant 10 to 15% of sleep troubles. Now is the primary insomnia disorder, which is around 10%. Yes. Yes, definitely. Coming to the evaluation. So there is a patient who has come, he himself has complained of a sleep trouble, or during your questions here they have come up with a sleep trouble. So we'll come to this, the sleep history and diary. I'll just quickly discuss about the history. Second is about the comorbidities. So mostly there would be a comorbidity of for a person who is having a sleep trouble. In 90% of cases, we will be able to identify a comorbid medical or psychological condition. In 10%, we will not be able to identify. That will be idiopathic insomnia. That is only 10%. So we need to screen for comorbidities. Here I would like to take a moment and talk about how to screen for mood and anxiety, which are the most common psychological problems right now diagnosed. So in a general practice, a lot of times, now being a psychiatrist, I tend to use different strategies to get the answers if they are having any anxiety or mood disorder. So now I have started using a technique. Of course, our setup is a quiet and a very secluded setup where the person is able to open up. We provide privacy, and I generally ask, do you feel restless? Do you feel anxious? Now, anxious also people understand. So at times, if they don't understand what is anxious, they will ask, sir, what do you mean by anxious? How do you define it? What are the symptoms? Otherwise, for whatever knowledge they have, they will say yes, 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 or they will say yeah, sometime. So that would be episodic anxiety, performance anxiety, and that could be a very well reason for the sleep problem. Tomorrow there is an exam, there is a presentation, or there is a important life event going on. This is a episodic anxiety. It is not a generalized anxiety, but that can cause a sleep problem because the mind is stimulated, sympathetic nervous system is activated, the sleep will not come easily. So I generally ask directly, do you have anxiety? Many people, around 60%, will answer yes or no correctly. If not, then we ask simply for anxiety, do you have excess worries? We all have worries, but excessive worry, like about future, exam, any random thing, that worry is so much recurring that it is interfering with your day-to-day practice. So excessive worry is a very simple word for anxiety. For mood disorders, especially depression, now I ask a very simple question. On a scale of 0 to 10, if 10 is very happy, 0 is very sad, how do you rate your current mood? Like right now, how are you feeling? So answer should be between 6 to 7 in a general setting. Person who has low phase, they will say 4 to 5. Melancholy, depression, they will definitely say 2, 1, 0 also. So these are very quick and simple tools to assess for anxiety and depression. But of course, there is certain requirements for a person to open up about it. There is a privacy, there is confidentiality, there is a non-judgmental attitude of the physician, which the person senses himself. When the person knows the doctor is in hurry, he will not want to open up his personal life to you. He will say, ki, this is my blood workup, please treat me for my diabetes. So that non-judgmental attitude of the physician, I think, does play a very important role. Medication and substance reviews, then sleep hygiene. We will have a talk about it as per the time, but we have a slide about it. So when we are evaluating a patient having a sleep related problems, these four things are important. Coming to the sleep history, there are a lot of things. Sorry for the cluttered slide, but there are a lot of questions which are needed to be asked about sleep if you want to get into that. It will start with the sleep schedule in day, which will include total time in bed, time to go to sleep, like fall asleep, waking time, time to get up off the bed, quality of night sleep, daytime napping, then timing of the naps, duration of the naps, quality of naps, number of naps, regularity of your naps. So lot of questions. Then there are more questions. Now about nocturnal awakenings, we ask number of awakenings, reasons for awakening, time to fall asleep after awakening, Then pre-bedtime behavior, which will be since evening, what do you do? Because we need to calm our sympathetic nervous system to be able to sleep properly. So we need to prepare a person or ourselves also to go to bed. We cannot be engaging in high intensity intellectual work and then want to sleep peacefully. So what do we do pre-bedtime? Then compensatory strategies. This is a very psychologically intended question about the thoughts during your time you are unable to sleep. That generally tells us about their worries, because that is the time when no one is watching you and your mind comes up with all the worries. So what do you think when you are trying to go to sleep? These are behaviors and thoughts. Then a detailed history of the addictions. So addictions are generally alcohol, opioids, stimulants, benzodiazepine, which are sleeping drugs. We'll talk about it. Then nicotine, tobacco. So these are addictions. Yeah, digital addictions, Instagram, reels. So these are the addictive substances or behaviors we need to ask questions. Then more questions about the withdrawal or inability to sleep without consuming a tablet. Then the time spent in bed in awake state in whole day. This is a part of your CBT for insomnia or bed sleep hygiene. That how much time do you spend on the bed when you are not sleeping? So this has to do something with conditioning of the mind. So certain places, for example, if you go to a temple, if you go to a meditation hall, there is an automatic silencing of sympathetic system. You feel a calm. That is a conditioning the mind has developed over the years. मंदिर में जाएंगे तो शांति मिलेगी. बचपन से parents have told, you have experienced, you have told your mind. Now you eventually feel it yourself. So this has to do something with conditioning. So if your bed is always used for studying or preparing projects, you will not associate bed with sleeping that easily. Now talking about things more objectively, as per the ICSD International Classification of Sleep Disorders 3, which is the latest version, ICSD 3 says a sleep onset latency of more than 30 minutes. If a person takes more than 30 minutes to go to sleep. Wake after sleep onset. After you have slept, if you need more than 30 minutes to go to sleep again, then it is a problematic sleep. Total sleep time of less than 6.5 hours in a day. The sleep problems happen more than 3 nights in a week. It persists for more than 3 months for chronic insomnia, which causes daytime impairments like fatigue, poor concentration, mood disturbance. So then these things qualify a person to be diagnosed with insomnia disorders. Talking about the management. So now we have understood that this person has a sleep trouble. Now what to do? Order a sleep study. Give a benzodiazepine, a sleeping pill. So I would like to stress upon here, there are a lot of non-pharmacological measures which are approved. Meta-analysis has been done, RCTs have been done, and they have been shown to have significant impact. The only problem is we don't have patience and time to tell it to the patient, and the patient also doesn't want to practice it easily. There is something called CBT for insomnia, cognitive behavior therapy. The awareness is so low that even the psychiatrists don't know about this. Leave about the psychologist who has to practice it. So CBT is always a well studied RCT done and approved treatment for many psychological conditions. I think we will talk about it, but it has the components of stimulus control, sleep restriction, cognitive restructuring. If I have to talk one line about each of it, the stimulus control would mean that during your bedtime, 1 hour before you're going to bed, the stimulation should not be included there in your life. Like mobile, engaging in a serious discussion. You're giving food to your mind to digest. So it will not rest. Simple. So this is something called stimulus control. Then there is sleep restriction. Sleep restriction means to be in the bed only when you want to sleep. You're not able to sleep, wait for 20 minutes, come out of the bed. Now you go to your sofa, chair, do your Instagram reels, study novel, whatever. But 20 minutes if you're not able to fall asleep, come out of the bed. Go again when you're feeling sleepy. So the bed is a place where you sleep only. That is sleep restriction. Cognitive restructuring is a very important and subtle things. People have belief systems and that develops anxiety. So what kind of a belief? I just give an example. If I don't sleep 8 hours, my day is going to be fully ruined. And that creates anxiety, chain of thoughts. Or how much time has passed since I am in bed? Oh, 15 minutes. Oh, 18 minutes, 20 minutes. So, so I need to fall asleep within 20 minutes or 30 minutes. So anxiety about that. So anxiety about not able to sleep, that causes sleeplessness. So that all comes under cognitive restructuring. So we need to understand the belief systems of the patient and correct it. Sleep hygiene, I think, which every physician should give a handout or maybe talk about it when the problem is stated. I'll cover up a checklist about sleep hygiene in the next slide. Yes, that will come under the sleep hygiene. We'll discuss in the next slide. Then there are relaxation techniques, mindfulness, which someone should practice if they are not able to fall asleep before going to medications. So sleep relaxation techniques, one of them is taking a warm water bath, relaxes the sympathetic system. Mindfulness, relaxation, there is Jacobson relaxation technique where sequentially muscles of the body are relaxed. People also go opt for meditation practices before going to sleep. People also go for journaling. If there are a lot of thoughts which come when you sleep, you write all of it, take 30 minutes for that, and then peacefully go to bed. So these three things are usually suggested before we recommend a medicine. And if we have to recommend a medicine, we start slow and for short time. The sleep hygiene, there are different categories to talk about, like sleep schedule. So same time going to bed, waking up. Sleeping environment is also important. Cool, quiet, dark, comfortable mattress, all of it plays a very significant role. Then pre-sleep routine, which is relaxing activities. Avoid screen 30 to 60 minutes before bed, like sir said, the iPads, mobiles. So avoiding them around 60 minutes before you go to bed. Diet and drinks, avoid caffeine, nicotine, heavy meals, alcohol before going to bed. Physical activities, which is exercising regularly and avoiding rigorous exercise 1 to 2 hours before sleep. Then daytime habits, which is getting natural daylight during the daytime, avoiding long naps during daytime, and of course managing the stress. Association with bed, use bed only for sleep and intimacy. Avoid work, TV, eating in bed. Then managing worries, which is journaling. Write down your concerns, to-do list before you go to bed. Practice relaxation techniques. So these are something which is called sleep hygiene checklist, and these should be shared with patients to start practicing, because going to medicines for sleep can be very dependence producing thing because of the drugs. We will talk about the drugs now. Pharmacological options should usually be used for short term, between 2 to 4 weeks ideally. So I've written ideally mainly because in Indian guidelines, because of the dearth of CBTI, cognitive behavior therapy for insomnia, in Indian guidelines, the short-term use may be expanded to 6 months. In international guidelines, it is said 2 to 4 weeks, but Indian guidelines say that up to 6 weeks we can use a medicine for sleep problem. Now, talking about the classes of medicines which we can prescribe. Benzodiazepines, so clonazepam and lorazepam are used. Zolpidem, the Z drugs are zolpidem, zopiclone, which are available in India. Melatonin and melatonin agonists like agomelatine, melatonin 3 mg, which are used for circadian rhythm disorders. Low dose antidepressants, they lot of times improve sleep, anxiety, and mood, all of it. So trazodone is very safe, 25 milligram. Mirtazapine, very safe, 3.5 milligram or 7.5 milligram. These are antidepressants. Then the newer category is orexin receptor antagonist, which is lamborexant and suvorexant, which is now available in India. There are low dose antipsychotics which we recommend to certain class of patients, which I don't think should be recommended routinely and by general physicians also, because of the metabolic risk factors associated with it. But there are quite a few options to handle medically also. But overall, the duration should be between 2 to 4 weeks, and try to educate the people about sleep hygiene and CBT for insomnia. Between? So yeah, this is one of the slides which compares benzodiazepines primarily. And the benzodiazepines is something which we often use very commonly. So I'm just going to discuss about what benzodiazepines and how they act. What are the benzodiazepines? Half-life. So basically the addiction potential, we are all concerned about it. Which benzodiazepine will cause the most addiction? Yeah, alprazolam. So there is a reason why some benzodiazepines cause more addiction. So it is one of them is the onset of action, the duration of action, and the potency. The more potent, the fast acting, and the short duration will produce most dependence. For dependence, there's another factor is a personality. A person might have an addictive personality, and a person might have a non-addictive personality. Those who have non-addictive personality, they will also question about taking a PAND, or anti-acid. I don't want to be dependent on any medicine. This person is very likely that he will not develop a dependence. But there are people who want to have easy way in life, so they are more prone to addiction, and they will have higher risk of developing dependence. Talking about alprazolam, that is Restil, half-life is 12 to 15 hours. So most of the drug will be eliminated in 12 to 15 hours. Onset is very fast, potency is very high, and therefore the abuse risk is very high. The typically used medicine for sleep is one is Restil and then second is lorazepam. Lorazepam is better in terms of addiction potential than alprazolam. The half-life is similar, 12 to 18 hours. The onset of action is intermediate. It takes time, 1 hour, 45 minutes to 1 hour. The potency is also medium, but abuse risk is still higher than the alprazolam. Alprazolam causes euphoria, but the lorazepam doesn't cause that euphoric effect. Therefore, the addiction potential is lesser than the alprazolam. Diazepam is very similar to lorazepam in all activities, but differs in the site of metabolism. So, diazepam is mainly metabolized and excreted through kidneys, and the half-life is the most different thing, which is 20 to 80 hours. Because of such long half-life, the chance of dependence on diazepam is lesser than the lorazepam. So earlier Valium was very frequently used by physicians, which is still used because of the half-life and relatively lesser risk of dependence. Clonazepam we use very frequently. It is long acting, reduces anxiety, and has a lower dependence potential than the other molecules because of the slower onset of action. Talking about the management in general, so when there is an acute insomnia, like which is less than 3 months, a person saying that since only 3 months I am developing a sleep problem. So first thing to do is talk about sleep hygiene. Then add a short course of hypnotic, a benzodiazepine or a Z drug, solpidem. Then reassure that these are normal and it can be cured. Maybe we need to refer to CBT for anxiety or anxiety related to sleep problems. For someone who has comorbid depression or a chronic sleep problem, which will form the major category of patients. So treating the underlying cause is very important. We cannot treat a sleep disorder patient with anxiety with only benzodiazepine. Unless the anxiety is controlled, no sleep medicine is going to work with its full capacity. The anxiety will not let the person fall asleep. So basically anxiety, what does it do? Anxiety activates the sympathetic nervous system. So that person has a active mind even when he is on bed. So how do we expect that this person will go to sleep every day normally? So we need to treat anxiety and then only the sleep will improve. It might take time to improve anxiety because anxiety can be a personality also. Anxious personality disorder is a disorder. So that these people have chronic sleep related problems. They will say कि बचपन से नींद नहीं आई ठीक से because they are always anxious. So we need to assess that and of course refer to a specialist to treat these things because these are not very easy to be treated. So these will require antidepressants apart from the CBT. Antidepressants will be an essential part of their management. Then pain related sleep problems, of course, controlling pain, then a sedating antidepressants like mirtazapine and trazodone. So pain related, we have seen 15 to 20% patients have a pain related cause of for sleep disorder. Now when to refer? So a persistent symptom for more than 3 months despite the treatment. So we have followed all the things. You have done it by yourself for all the things for 3 months and there is a persistent problem of sleep. So now it is a chronic sleep, chronic insomnia. Chronic insomnia and the comorbid psychiatric conditions, we need to refer it to a specialist. When we suspect there is sleep apnea, we have very well understood how to approach a sleep apnea or screen a patient for sleep apnea. Restless leg syndrome, so neurological causes. So any suspicion of neurological or a sleep apnea, we should definitely refer or do a sleep study. Complex comorbid psychiatric illnesses, including benzodiazepine dependence. So when we encounter a person having benzodiazepine dependence who has been taking a benzodiazepine for more than 3 to 6 months, that is a time we need to be alert because benzodiazepines can cause cognitive impairment, memory impairment, dependence, which is going to be very problematic for a person if not handled at early course of treatment. So these are the conditions when we should refer a patient. Taking the key takeaways, so cause, identify the cause. So only 10% is primary insomnia. 90% we should be able to identify cause. If you're not able to identify, it's likely a psychological cause. The cognitive behavior therapy, which is the first line for all types of insomnia and sleep related problems. Short-term hypnotics are only as an adjunct. They should not be given for a longer term. Comorbidities management should form a core treatment approach and sleep hygiene is basic for everyone. So thank you for your attention.
Thank you, Gopal.
You were asking if we can give the hypnotics for short intervals and multiple times. Yeah, we can do, but it is not solving the primary problem. It has not helped to address the primary cause of sleep problem.
I think
That will depend person to person. If you get stressed after reading a religious book, what will happen to me after my death and all, it's not a good thing. But if you feel relaxed, happy after it, it's relaxing. Yeah.
the Z drugs and the benzodiazepines.
Yes, so I can tell you about the Z drugs differences. So Z drugs are atypical benzodiazepines which act on benzodiazepine receptors but on a different receptor. Benzodiazepines act on alpha subunit, they act on beta subunit. The onset of action is fast, but they do not cause euphoric effects. They do not have a short half-life. They have a short half-life, but they are not immediately inducing a euphoric effect. So that is the reason that they are known to be non-dependence producing. They do not cause any respiratory depression which is seen in benzodiazepines. So Z drugs are relatively safe.
But they can be equally addictive, no?
It is addictive, but less than the benzodiazepines. Significantly less.
Antihistamines, yeah,
They
a lot
can
of
be
patients use antihistamines.
Yes, they can be used, but if they are getting dependent on that without, so it is a drug dependence.
And
the category.
they would also aggravate nocturia actually. They have the lower urinary tract symptoms, no, with antihistamines, so I would
They can
probably not consider it as an
So
ideal drug.
the thing to understand is, are we treating the root cause?
Yeah, that's true.
Warm bath. Warm bath.
Blue light or red light?
No, avoid blue light. Yeah.
Sir,
Melatonin is a natural hormone.
what is the ideal dose of melatonin?
Melatonin is 3 milligram to 5 milligram. More than 10 milligram or 10 milligram is not scientifically approved. It can cause daytime side effects or early morning jitteriness. So 3 to 5 milligram is an optimal dose. It has to be taken 45 minutes before going to bed, and it also requires avoidance of light exposure because the melatonin hormone will get destroyed with light exposure. So melatonin is usually very good for chronobiology changes of sleep pattern. It is not a hypnotic per se. It is not a hypnotic drug. It will assist in sleep, getting early sleep, but it will not definitely make someone sleepy. If you are after taking melatonin, if you are working, you will not feel sleepy.
But do you recommend melatonin for all jet lag, for frequent travelers?
Yes.
You recommend it?
It is for jet lag. It is needed only because of the time
drug of
change.
choice.
So you will recommend if somebody is, and therefore they continue it till they overcome the jet lag.
Yes.
But
It
I would
may be
like
needed to be accompanied with a or with a zolpidem for severe, like if traveling, if the time difference is 12 hours. So then we will need a stronger drug to overcome that. If it's 6 hours, 5 hours, 4 hours, a melatonin can be sufficient.
And
I also wanted to
Rajan,
comment.
You can't be jet lagged and come back and take melatonin and expect to sleep if you're going to continue working after taking it.
No,
I
true.
think that's very important also. Then you need the zolpidem.
But there are people who take melatonin even to fall asleep. Without the jet lag, because they feel these hypnotics are more dangerous. So let me take melatonin. So there are two things I wanted to ask. One is, I agree that melatonin is a drug of choice for jet lag. That there are people, which includes my own brother-in-law, who keeps popping melatonin because he cannot sleep. Second, in this group, I would like to ask, I'm sure there are enough patients and doctors who keep popping pills and are popping pills endlessly. So where do we get to this bottom of treating insomnia? Yes, we need to refer to psychologists, psychiatrists, sleep specialists, but there is a lot of abuse of these medications.
Yes,
and people just do CT all. People are taking this for years together.
That's the
So we are
problem with
headed to
India,
a total
Indian management, because everyone is so occupied and busy. The doctors also don't spare time to explain the sleep hygiene, the CBT for insomnia. The patients also don't want to put their hard work.
And you try telling an
They will ask
elderly,
me, sir, इसमें से which one is having the least side effect? Okay, this is safer for me than going through my mental troubles.
Actually, the safest side effect, one that you mentioned, is not even available in India. Oxazepam. I think oxazepam sounded the safest from what I saw.
no, because if you try taking an elderly off Restil, he will never come back to you. He or
Yes, so
she.
it is a, I think that's one of the case discussions.
Yes.
We will talk about
So
it.
we'll talk about that. I think if anyone wants a cup of tea, I think Prakhar, there'll be a lot of questions because our last case is around insomnia. So we'll see.
Sir,
how
one more
Prakhar
question
deals
about
with it.
people.
Just one second, Hemant. We need to get everyone to have a cup of tea so that we can have a good role play session. And Prakhar is there. So
Yeah,
come back to the hall after
can make
any one of you wants
Yeah,
a tea,
yeah,
and
it
we're
is there.
sitting around each other here.
So thank you for coming back after the tea break. We were a bit jittery sending you outside. We thought you might not come back, but you've heard the lectures from the morning, and I think the first thing I would like to really appreciate is this eclectic group of doctors. It's not just pulmonologists, which is a relief. There are dentists, and also there are family physicians. So which is the best, and ENT. So I think it's a great group mix of people. And you also heard both the speakers say about looking after patients holistically, history taking being important in patients with sleep apnea, and all the other issues about communicating better. You heard Saurabh say communication improves compliance. So we thought it's a good exercise here for all of us, despite it being a Sunday afternoon, to actually display to you what communication can actually make or break your deal in the consulting room. So it's a little bit of fun. Actually, it's all of fun. And we really don't, nothing serious, no hard feelings. And Leena, my colleague, will explain to you about what we're going to do and about role plays.
Okay, so we're going to be looking at communication, okay, and we're going to be looking at difficult conversations. And the idea that a difficult conversation is like a procedure, okay? So, in any procedure, so if you take a surgical procedure, you have tools, you have techniques, and you have training that's necessary to conduct that procedure, okay? So, in communication, we have certain techniques and tools, and we will share those with you, of course, as we go along. And we believe that there's a certain level of training required. And we have experienced this with our own practice, that initially, when you have to sit down and have a difficult conversation, it, it doesn't come very naturally initially, and you have to sort of keep practicing at this skill. And at some time, it becomes easier to start having difficult conversations. Okay, so that's the training part. So one of the techniques of training that's used in communication skills is the use of role plays. And a role play is, it's actually a lot of fun, and we hope that you have fun too. We've done this in a lot of places. It's fun. It's a fun way to learn. So we have volunteers. So what we do is we request some of you to volunteer and play the role of the doctor who has to lead the difficult conversation. Oftentimes, often a patient and a relative, okay? And we hope that people volunteer And sometimes we can't find volunteers and we volunteer one of you, but we hope that that doesn't happen. It's a very safe space. It's meant to learn. We laugh with each other. We don't laugh at each other. So it's really a learning process. And at the end of the role play, we all reflect. Okay, so we ask the participants how they felt, if there's anything they think could have been different. We ask the audience for feedback, and the whole thing is just with the idea to learn. Okay?
And so whatever happens in this room stays in this room. You go out, you forget it, right? So
Yeah.
no hard feelings. It's all just for fun. So
Yeah, it's just for fun.
So we request a doctor. You're the patient.
Everyone wants to be a patient. We have lots of people who volunteer for patients. So Dr. Saurabh's volunteered to be the patient, Dr. Pratibha is the wife, and we need a doctor. Okay. And when the role play actually takes place, we will step out and these people really, they become real characters in that situation, okay? So you guys will be talking to each other. All of us are not here at the time.
Patient is here and, patient has come to meet the doctor and she has to try to convince him to get a sleep study done. That is the setting and we can see where all, how this conversation goes.
Hello.
Hi,
Hi. What's your name?
I'm Saurabh.
Swarab. Okay. What's your age?
I'm 45.
45. And what do you do? What is your profession like?
So I have a business of my own.
I have how much time?
We are not here.
Okay. आप क्या करते हैं?
So मेरा business है. So I run a business house.
Business मतलब क्या?
Export. So I have a clothes factory and I kind of export clothes outside.
Very nice. तो आप आज यहाँ आए हैं, आपको क्या प्रॉब्लम है?
नहीं, मेरे को तो कोई प्रॉब्लम नहीं है. मेरे को तो मेरे फिजिशियन ने बोला कि आप जाके स्लीप वाले डॉक्टर से मिल लो.
तो आप फिजिशियन के पास क्यों गए थे?
मेरे को थोड़ा सा चलने में सांस फूल रहा था.
सांस फूल रहा है. ओके. और क्या प्रॉब्लम है?
बैठा रहता हूँ तो मुझे कभी कभी लगता है कि मैं कुर्सी बैठे बैठे थोड़ा सो जाता हूँ. तो मैं वो तो मेन प्रॉब्लम नहीं थी बट कुछ दिन से मुझे लग रहा है कि चलने में मेरे को सांस फूलने लगता है. तो फिजिशियन के पास गया, उन्होंने अपने सब टेस्ट वगैरह कर लिए, कुछ पीएफटी करा, सीटी स्कैन वगैरह करा, उन्होंने बोला सब ठीक है. तो उन्होंने मेरे को बोला कि आप एक बार जाके स्लीप के डॉक्टर को मिल लो.
तो आपके प्रोफेशन में आपका कुछ डस्ट एक्सपोजर या आपका कुछ केमिकल एक्सपोजर?
नहीं,
ऐसा कुछ नहीं.
और मेरा जैसे उन्होंने लंग का टेस्ट वगैरह किया, सीटी स्कैन, पीएफटी, वो सब वो बोल रहे थे सब नॉर्मल है, कुछ प्रॉब्लम नहीं है.
आपको पहले कोई बड़ी बीमारी हुई है?
कुछ भी नहीं.
कुछ भी नहीं है. ओके. आप कभी एडमिट?
मैंने ऐसे कुछ खास टेस्ट कराए नहीं है मतलब.
आप अपना एनुअल चेकअप कराते हो?
नहीं, कुछ भी
नहीं कराते हो. ओके. और आपके फैमिली में किसी को कोई बड़ी बीमारी है?
हाँ, my father died of heart attack when he was probably 52.
ओह. ओके. एंड मम्मी को या भाई बहन किसी को कोई हेल्थ इशू?
So the entire family is overweight, but I think nothing else.
ओके. और अभी आप कोई दवाई पे हैं?
नहीं, कोई भी दवाई नहीं.
कोई दवाई पे नहीं है. ओके. आप
ब्लड प्रेशर की दवाई चल रही है ना?
ब्लड प्रेशर की दवाई, हाँ, ब्लड प्रेशर की दवाई चल रही है.
ब्लड प्रेशर की दवाई चल रही है. ओके. आप क्या लेते हैं?
एमलोडिपिन.
तो आपका बीपी ठीक रहता है?
हाँ, मतलब मैं गोली रात को खाता हूँ, एक ठीक रहता है.
ठीक किसको बोलते हो आप?
ठीक, मैं मतलब डॉक्टर के पास जाता हूँ, मेजर करते हैं, वो बोलते हैं कि ठीक चल रहा है. आई हैव नॉट मेजर्ड इट एट होम.
आपने घर में
घर पे नहीं मेजर करता.
लगभग कितना रहता है?
तो लगता है कुछ 135 ऊपर वाला रहता है और कुछ 90, 91 ऐसे कुछ नीचे वाला रहता है.
और डॉक्टर को ये एक्सेप्टेबल है?
हाँ, वो मेरे फिजिशियन जो है वो बोलते हैं कि ठीक ही है.
अच्छा, ठीक है. तो आपको ये जो सांस फूल रहा है, इसके साथ आपको कुछ छाती में दर्द वगैरह तो नहीं होता?
नहीं, कुछ खास बात नहीं है.
पसीना आना, घबराहट होना?
पसीना मुझे रात को जब मैं सोता हूँ तो कई दफा मेरे को पसीना आता है, बाकी दिन में तो ठीक ही है, ऐसे कोई प्रॉब्लम नहीं है.
आपकी रात की नींद ठीक है?
नींद ऐसे तो ठीक आती है, पर मुझे लगता है बीच में मेरे को एक दो बार उठना पड़ता है पेशाब वगैरह जाने के लिए, और कई दफे जब सुबह सो के उठता हूँ तो लगता है कि थोड़ा 1-2 घंटा और सो सकता हूँ.
ओके. और ये आपको कब से हो रहा है?
ये तो मुझे लगता है कई साल से हो रहा है, बट मुझे लगता है ये को मतलब मैंने इसको कभी ध्यान नहीं दिया कि कोई मेजर प्रॉब्लम है. ये
10 साल से हो रहा है ऑलमोस्ट. एंड आई थिंक अभी मैंने एक वीडियो लिया है, आप वीडियो देखेंगे प्लीज? मैं उनकी वाइफ हूँ. तो रात को सोते समय बहुत जोर से खर्राटे भरते हैं
और मैंने एक वीडियो लिया है उनको, वो तो प्रॉब्लम इनको है कि आपको है? वो प्रॉब्लम है जिसकी वजह
अरे ये इनको ज्यादा प्रॉब्लम है, मैं तो सोता रहता हूँ, ये सुबह उठ के चिल्लाते रहते हैं कि मुझे सोने नहीं देते, मैं खराटे भरते इतना तेज थे।
तो ये खराटे भरते हैं तो चोक भी करते हैं?
हाँ, बीच बीच में सांस लेना भी बंद कर देते हैं। आप वीडियो
ओहो।
देखिए, इतनी जोर जोर से
Okay.
खराटे भरते हैं कि साइड के रूम में बच्चे भी उठ के आ जाते हैं कि कुछ देखो पापा को क्या हो रहा है।
1 BHK है कि 2 BHK? ओके, ओहो। तो इनके फैमिली में आपका वेट कितना है?
मेरा वेट होगा अराउंड 80 kg।
उनका हाइट लगभग कितना है?
5'5" होगा।
5'5", मतलब ओवर वेट तो है।
हाँ हाँ, मैं बोल रहा हूँ ना, मेरी फैमिली में सब ऐसे ही हैं जैसा मैं हूँ।
पुरुष
खाते पीते घर के हैं।
खाते पीते। ओके, तो आपके घर में कोई और भी खराटे लेता है?
मुझे लगता है खराटे तो हमारे यहाँ सभी लेते हैं,
सभी
मतलब मेरे पेरेंट्स भी लेते, मेरे फादर भी लेते थे, मेरी मदर भी लेती है, और मेरे जो भाई था वो भी लेता ही था। अब तो खैर वो अलग रहता है तो मेरे को पता नहीं, बट पहले तो जब था लेता
और आप साइड में सोते हैं कि आप बैक पे सोते हैं?
मैं तो साइड में ही सोता हूँ, बेड पे तो मैं सो ही नहीं सकता।
आप साइड में सोते हो? आप पिल्लो लेके सोते हो?
पिल्लो लेके सोता हूँ।
ठीक है। और आपने कुछ नोटिस किया है क्या कि आप जब आप कुछ अल्कोहल वगैरह लेते हैं या कुछ लेते
नहीं,
हैं?
मैं अल्कोहल लेता ही
नहीं लेते। ओके।
दिन में टीवी देखते देखते सो जाते हैं।
दिन में
हाँ,
टीवी?
ये तो शायद इन्होंने कभी नोटिस करा, मेरे को भी कभी लगता है जैसे मैं फैक्ट्री में बैठा हूँ, ऐसे खाली टीवी चल रहा है, मैं सो जाता हूँ। ये तो होता रहता है मेरे
फैक्ट्री में टीवी देखते हो आप?
कभी कभी खाली बैठे कोई काम नहीं तो बैठे दिखे रहते हैं।
और ये ड्राइविंग करते हैं तो कभी बोलते हैं कि मुझे बहुत नींद आ रही है?
ड्राइविंग करते तो हमें नहीं सो जाते हैं, बट यदि कभी कभी हम लॉन्ग कभी जा रहे हैं आउट ऑफ टाउन, कोई और ड्राइव कर रहा है तो पीछे बैठे बैठे सो जाते हैं।
वो तो तुरंत 10 मिनट में नींद आ जाएगी।
और इनको कुछ खांसी जुकाम या नाक बंद या ऐसे ऐसे फ्रिक्वेंट तो नहीं रहता है? नहीं। और इन्होंने कभी बोला है कि मैं शर्ट टाई पहन रहा हूँ तो मुझे थोड़ा सा टाइट लगता है या कुछ इस तरह का?
नहीं
कुछ
बताया।
बट ऐसे तो ठीक है, मुझे लगता है वो थोड़ा ऐसे मोटा हो थोड़ा सा तो टाइट
पर
तो
आपको कुछ तकलीफ होती है?
नहीं, उससे कोई ऐसा मेजर इशू तो नहीं है।
ओके। सो आपको बीपी का प्रॉब्लम है और आपको बेसिकली जितना भी हमने बात किया उससे ये समझ में आया कि इनका बीपी का प्रॉब्लम है, जो इनका ऑलमोस्ट बॉर्डर लाइन ठीक है, मतलब बेस्ट ऑफ द बीपी कंट्रोल नहीं है। 135/40/90 इज नॉट बेस्ट ऑफ द कंट्रोल। और इनको दिन में नींद आ जाती है बिकॉज शायद रात में ये बहुत बार उठते हैं, है ना? और
2 बार तो उठना पड़ता है।
2 बार उठना पड़ता है। और इनके हिसाब से जो इन्होंने आपको वीडियो निकालने के लिए किसने बोला था?
नहीं, क्योंकि बहुत बार मैंने बोला हुआ है कि चलिए डॉक्टर के पास चलिए, दिस इज नॉट नॉर्मल। वो सडनली सांस लेना बंद कर देते हैं, तो फिर वीडियो निकाल के मेरे को इनको दिखाना पड़ा ताकि वो आपके पास आए।
नहीं, आपने बहुत अच्छा किया, आपका एक विजिट का पैसा बच गया। ये फर्स्ट होमवर्क है जो करते हैं। सो बेसिकली इनको शायद कहीं पे इनको स्लीप में, मतलब इनका जो सांस लेने की स्नोरिंग करते हैं और ये जो बीच में चोक करते हैं, एक्चुअली जो चोक करते हैं तब शायद इनका ब्रेन को ब्लड सप्लाई थोड़ा कम होता है और ये उठ जाते हैं, और शायद इनको ऐसा लगता है कि ये यूरिनेशन के लिए उठ रहे हैं या फिर इनका नींद डिस्टर्ब हुआ है। सो इसके लिए आजकल बहुत अच्छी स्टडी है, स्लीप स्टडी है। उसके अंदर मशीन लगा के देखते हैं कि आप ऐसे कितनी बार उठते हैं या आप ऐसा कितनी बार चोक करते हैं।
तो मैं तो 2 बार उठता हूँ।
2 बार आप उठते हैं, पर आप चोक ज्यादा बार करते होंगे, या तो वो मतलब कुछ सीवियर होता है उस पूरी रात में। समझो कुछ एपिसोड्स में आप उठ जाते हो, कुछ एपिसोड्स में आप नहीं उठते हो। सो वो स्लीप स्टडी से पता चलेगा कि आप कितनी बार आप चोक करते हो या आपको कितना स्नोरिंग होता है।
या क्या कोई ब्लड टेस्ट होता है?
नहीं, ये एक तरह का टेस्ट होता है जिसमें कुछ वायर्स और लीड्स लगा के रात में सोते वक्त देखा जाता है कि आपको कितना, आपका प्रॉब्लम कितना सीवियर है। एक चीज होती है कि आपको केवल स्नोरिंग हो रही है, उससे भी थोड़ा डैमेज होता है, पर यदि आपको स्नोरिंग के साथ आप चोक कर रहे हो तो आपको फिर आपका बीपी ज्यादा अच्छे से कंट्रोल में नहीं रहेगा, आपको कभी स्ट्रोक हो सकता है, हार्ट अटैक हो सकता है, बहुत सारे प्रॉब्लम हो सकते हैं।
बट मुझे तो ये सब कुछ भी है ही नहीं।
अभी है नहीं, पर हो सकता है। सो मतलब हम हो जाएगा तब रिएक्ट करेंगे तो थोड़ा देर हो जाएगा ना।
बट डॉक्टर, मुझे भी बोला गया था स्लीप एपनिया है 10 साल पहले, और मेरा भी स्लीप स्टडी हुआ था और मुझे बोला गया था सीपैप यूज करने के लिए। मैंने यूज नहीं किया और मैं तो ठीक हूँ, मुझे ना स्ट्रोक हुआ है ना हार्ट अटैक हुआ है। तो फिर मतलब ये तो मतलब डॉक्टर्स के पास जाओ तो वो बोलेंगे ही ना ये सब घबराने चीजों के लिए।
नहीं, मतलब नहीं हुआ है अच्छी बात है। लोगों को सालों तक हाइपरटेंशन और ये रहता है, हार्ट प्रॉब्लम थोड़ा थोड़ा रहता है, पर एक दिन अचानक से हार्ट अटैक आ जाता है या स्ट्रोक आ जाता है। सो if we are really conscious about our health, तो ये कराने में कोई बुराई तो है नहीं, थोड़ा सा पैसा खर्च है, ठीक है, पर यू विल बी डबली श्योर कि इससे जो डैमेजेस हो सकते हैं और जो हम प्रिवेंट कर सकते हैं, तो फिर कराने में हर्ज क्या है?
तो उस समय ना मैंने 1 हफ्ते तक मशीन यूज की थी, बट आई वाज नॉट कंफर्टेबल, तो मैंने रिटर्न कर दी। तो डॉक्टर के पास भी वापस नहीं गई थी मैं। और एक रात को मैंने इनको बोला था कि आप ट्राई करके देखो, मुझे सूट नहीं हो रही, आप ट्राई करके देखो, तो उनको भी नहीं पसंद है। तो यदि आप टेस्ट करके बोलेंगे मशीन यूज करने का, तो वो तो मशीन बिल्कुल यूज नहीं करने वाले हैं।
नहीं,
तो आप टेस्ट करने का मतलब ही क्या है?
नहीं, मतलब मैं वही पूछ रहा हूँ कि मान लो टेस्ट कर लिया, चलो हमने आपके कहने पे, आपकी बात पे हमने कर भी लिया, टेस्ट कर लिया, उसमें बीमारी कुछ आई मान लो, तो क्या करेंगे? मशीन लगाएंगे? तो मशीन तो मैं लगाऊंगा ही नहीं, चाहे कुछ भी हो जाए।
सो आपके पास चॉइस है, या तो आप मशीन लगाओ या फिर यू बी मेंटली प्रिपेयर्ड फॉर एनी इवेंचुअलिटी व्हिच यू कुड हैव प्रिवेंटेड। मतलब आप
नहीं तो डॉक्टर, अब ये थोड़ी है कि
क्या
मतलब
परसेंटेज है कि उनको कुछ हो जाएगा?
मेरे को क्या हार्ट अटैक आ जाएगा अगले साल?
मतलब आ सकता है।
नहीं तो ये गारंटी क्या है?
मुझे तो नहीं आया मैडम,
कभी भी
10 साल हो गए, मुझे अभी तक कुछ नहीं हुआ।
अभी अपनी आधी
अच्छी
लाइफ
खांसी हूँ, मैं चल फिर रही हूँ, सब काम कर रही हूँ।
10 साल में नहीं हुआ तो अब क्या?
ऐसा तो नहीं है कि 50-60 या 60 साल वाले इंसान को हार्ट अटैक या स्ट्रोक नहीं होता है, होता ही है ना।
तो मुझे लगता है वो तो 50-60 के बाद तो सारी बीमारियां आ ही जाती है आदमी को।
नहीं, सारी नहीं आती, ये स्लीप एपनिया इतना कॉमन नहीं है।
Thank you. Big round of applause. Thank you so much. Thank you. You can keep sitting. You have to leave?
No, yes,
5 minutes.
No, you have time. It's not so hard.
First we asked them how they all felt.
I really felt that it's a difficult situation. It is not so easy to convince. Actually, this is what practically happens in clinic also. No one takes it seriously till they see someone suffering or something happening to someone. They will always resist.
So you felt stuck.
Yeah, and I know it very well because my husband has sleep apnea and he uses CPAP. So, though I tell him to use daily, but many a times he doesn't use it and he feels कि मुझे तो कुछ नहीं हुआ. So it's like a daily battle, but it is a battle.
So I felt what every patient actually feels, but I think I mean in general what I in my practice do, I mean in clinic. So we run a sleep clinic in which we have at least 25 patients with sleep apnea coming. So some of them are on CPAP, some on BiPAP. So I ask them, don't talk, go outside and see what they are doing. So this kind of and then they're waiting to see me when 3 hours, 4 hours OPD, they come by 1 o'clock, everybody has to register. So they talk. And by the time they reach me, most of them would know what I have already told other patients. So this group communication between the patients is a good therapy. And many times, like I'm convincing, okay, I tell them, go to the sleep lab, okay, go to the technician, see what is happening there. So if they see, they kind of get sometimes they will get afraid. मैं तो बिल्कुल लगाऊंगा ही था. Sometimes they say अरे तो बेड पे सोना है, कोई प्रॉब्लम नहीं है. So means you familiarize with them that what you are actually, which you have not told me. So that is, I think, very important. Sleep study, you have to tell the patient what you will do. That it's not a blood test, it's not a ECG. You have to spend time on explaining the test. I think that's very important to convince.
The whole idea of... Can I say something? Yeah. So I agree with what you said. As a doctor, that is your response going to be. But as a patient's relative, I was thinking that, but why is she insisting कि मेरे को कुछ हो जाएगा? Okay, अभी तक नहीं हुआ है. So why is she insisting मेरे को कुछ हो जाएगा? So I think maybe the response would have been that it's good nothing has happened to you, but it is still dangerous and we are, it's not a safe situation to be in if something happens to you. So that empathy that it's good that it has not happened to you so far, I think that would have probably made me accept what you're saying better.
And also, I mean, telling that CPAP is not the only treatment. So it's not just the machine. So you can have other options also, which can be explored. But at least first we have to know whether you have sleep apnea. Yes.
So the moment we talk about CPAP on the day one, they don't want to do it. It's like it's convincing them to get it and then they see from there.
Yes, I never tell them CPAP on first visit. Yes.
So I think what we would like you to take home is two things. What do you say to convince a patient is one thing. How do you say that is the other thing. So how do you say that? Leena will give you some tools, etc. But like Pratibha said, when somebody is trying to ask repeatedly, I am fine, and we are trying to make the patient aware. There is a technique in how you kind of portray a scary scenario. Like you could have got this, you could have got that. There's a way to say it. So I will circulate the mic to see how other people say it so that you learn from the experts. But the best way, what we need to take home from this is all the good things also and learn how to get out of sticky situations. So how do you do it, Shivan?
So typically about telling them about sleep studies. So I try and explain to them the disease physiology. I give them a very layman kind of example that basically आपकी सांस की नली सिकुड़ जाती है या बंद हो जाती है जब आप सो रहे हैं. And I think post COVID everybody is very receptive to oxygen levels. So I tell them इसकी वजह से क्योंकि हवा नहीं पहुंच रही तो ऑक्सीजन नहीं पहुंच रहा. आप तब उठते हैं जब आपके ऑक्सीजन का लेवल एक लेवल से कम हो जाता है ब्रेन में. अब उसमें भी कई बार माइक्रो अराउजल्स होते हैं जो आपको रजिस्टर नहीं होते, जो आप शायद हाथ पैर चला के या करवट बदल के वापस सो जाते हैं, या और कुछ अराउजल्स होते हैं जैसे कि आप उठते हैं पानी पीने के लिए या बाथरूम जाने के लिए या आपकी नींद खुलती है, आप इधर उधर देखते हैं और वापस सो जाते हैं. तो ये जो आप बार बार उठ रहे हैं उससे एक तो ऑक्सीजन की कमी से जो नुकसान होता है वो तो होता ही है शरीर में, उसके अलावा आपकी क्वालिटी ऑफ नींद जो है वो पूरी नहीं हो रही. इसलिए आप जब सुबह उठेंगे तो आप चिड़चिड़े रहेंगे, आपके पास एंड ऑफ द डे एनर्जी नहीं रहती फॉर सोशल कमिटमेंट्स या गिव टाइम टू द फैमिली. आप थके रहते हैं, आपको नींद ज़्यादा आती है, आप सुबह भारी सर के साथ उठते हैं. एक्सरसाइज करने का आपका रूटीन अगर आप चाहते हैं तो भी नहीं बन पाता क्योंकि आपकी क्वालिटी ऑफ नींद जो है वो पूरी नहीं हो रही है. तो ये सारी चीज़ों से आपकी हेल्थ और लाइफ दोनों चीज़ अफेक्ट हो रही है. सो आई गिव देम दिस एग्जैक्ट एग्जाम्पल अबाउट स्लीप स्टडी. आई एक्सप्लेन इट टू देम कि अगर लेवल 1 है तो क्या प्रिपरेशन करनी है, आपको वहाँ सोना होगा बट घबराने की कोई बात नहीं है. आप उठ के मशीन के साथ वॉशरूम वगैरह यूज़ कर सकते हैं, टेक्नीशियन वहाँ होता है. दवाइयाँ आपको क्या लेनी है, कितने बजे आना है, आप कितने बजे जा सकते हैं, नेक्स्ट डे आप रूटीनली काम पे जा सकते हैं. ऑल दीज थिंग्स आई टेल देम. So, and when they talk about treatment options, I always tell them one step at a time. आपकी रिपोर्ट देखेंगे अपन, उसमें देखेंगे क्या है और कितना सिविरिटी है, अपन उसके हिसाब से ट्रीटमेंट ऑप्शंस डिस्कस करेंगे. Without seeing the report, अपन कुछ भी डिस्कस करके कुछ पॉइंट नहीं.
So yeah, for us as doctors, the oxygen level is important and the consequences of that is important. But for patients and their relatives, their quality of life is important. So maybe we need to start focusing equally on all that than just caring them about what could happen to them because of.
What can happen is that sleep apnea doesn't get treated. So sometimes, it works against them also. When you try them, you can get a heart attack, stroke, cardiac failure on the first consult, when they have not even built confidence into you. It might come out very strong.
Exactly.
You're trying to sell the sleep study.
What they are suffering from.
Yes.
Important to convince him to have the sleep test. So you say, because like she said, post-COVID, people are aware of oxygen being low and its consequences, saying that that's the important thing. So with that, we'll go to Leena and just hear how to say these things. It's a very important tool that we need to learn. And with that, I would also like you all to comment on what the doctor did before she started the consult. So once Leena finishes, just recap how the conversation went and what all went right and wrong, but that we'll ask your opinion once Leena finishes.
Just give it, but I think one point that Saurabh mentioned, he never discusses CPAP on the day he asks for the test. And I remember when one of my seniors once told me he never asked for sleep studies when the whole sleep medicine was just evolving. And I said, why? He said, no, because then they need CPAP and they won't be able to afford a machine. And that was the end of the study. So, talking about CPAP, I think that's a very important point. On day one, actually shuts off the patient from everything else that they want to do in life.
So many times patients think that we are selling CPAP. I mean, I work in a public hospital, we don't charge for a sleep study, but patient has to buy the CPAP. So they always have this idea कि ये मेरे को मशीन बता देंगे, मेरे को 70,000 का मशीन लेना पड़ेगा, इनको कमीशन मिलेगा. I mean, patients have that mentality, and unless we kind of refrain from that conversation in the beginning, it's very important. So, yes. So many times I will tell patient, okay, I've told you, you don't want, no problem. Come after 3 days, I'm telling you, read these points from Google, come back, we can discuss again. So a lot of people will do that. They will say, okay, doctor, I'm sitting outside, I'll come back in 15 minutes. Yes, they will search, they will read and come.
So what we'll do is, we thought that we'll do a role play and then we'll discuss one tool at a time so that we can kind of see how we're applying these things. So as I said when we started, difficult conversations are like a procedure. We have techniques, we have tools, and we have training. So the techniques, one of the techniques that we use, and we can reflect on whether we saw it being used here, is the ask, tell, ask. Okay? So it's always important to ask the patient first what they know so far, what they have been experiencing, and also to acknowledge the relative who has come. And oftentimes we need to give what's called a warning shot. Okay? We know that these tests are expensive. We know that the rental of the machine can be expensive. So sometimes if we just say up front that you're going to need this test or you're going to need this machine, the patient may not be ready to receive that information. And that itself may, stop any further discussions. We need to give a warning shot sometimes that what you're telling me sounds like something we need to explore further, or we need to give that warning shot that we're going to be discussing something more serious. And we'll speak about these tools. So we'll start with the spikes tool for difficult conversation. Now, this is a tool which helps us have a kind of checklist in our mind for what we need to cover when we're going to have a difficult conversation. So we start with the S, which is the setting, okay? The setting is, for example, how is the seating arrangement? Are you sitting in a way that is, and that's why we leave the chairs for you to arrange. Are you sitting face to face with the patient? Are you sitting a little closer to the patient so that they feel that there's no barrier between the two of you? How are you positioning yourselves, okay? First of all, where is the conversation taking place? Obviously, in this type of clinical setting, it'll probably be in the doctor's office. Things like, did you greet the patient when they walked in? Do you know the patient's name? Do you know the person who's accompanying the patient? Do you know that person's name? Okay. Have you introduced yourself to the patient? So all these things kind of just set the tone for how that conversation is going to happen. The P is the perceptions. So that's where you ask the patient that what are your perceptions about this? What are your concerns? You may not need to use the word perception, but you can say, "Aapko abhi tak kitna malum hai? What do you know? What are your concerns?" In this case, the wife wanted to show a video, so she had already come with some of her homework done. I is like an invitation, okay? As Dr. Rajan mentioned, and I think Dr. Sir also mentioned that sometimes we do not give all the information in the first consult, okay? There needs to be some invitation from the patient that they are ready to receive this much information. Sometimes you can only give a little bit, and you have to keep gauging if you're getting an invitation for more information, okay? So the I is invitation and information, but it's more invitation. You have to really, it's a soft skill that you will develop where you're assessing how much the patient is able to take and whether you should, proceed with more information or if you should leave that for another conversation. Knowledge is we ask the patient how much they have understood from this. What have they understood from this conversation that you have, the information that you've given, what have they understood? E is emotions. Always expect emotions. There's going to be some emotional reaction to what you are saying when it's a difficult conversation. You may be accused of, creating tests and creating rentals. You may be accused of giving, like for example, our wife here said that I've not used it, I'm fine, you doctors just want to prescribe tests. So there'll be some kind of reaction. So how to deal with those emotions? It's also another tool which we will discuss a little later, but for now, we just need to know that there will be an emotional outburst to what we're saying. And of course, the summary. It's very important at the end of every consult to have a quick summary, even if it's only 3 take home points. Sometimes you might say that, okay, when you go home, I want you to think about this. I might need to have this test done. Or if we're not talking about the test right away, we can maybe give them some literature to educate themselves. But there has to be a closing point to that consultation where you summarize, okay, for the patient what has just happened. So that's the spikes tool.
So, given that you know about spikes now, in the role play we just had, what all are the things that you saw went right? So that you can apply it in your clinical practice. Sir, in fact, has it recorded, but we will not replay it. What all went right in this role play?
This is a communication workshop, so we need everyone to
communicate. Come on, you all saw it.
Okay.
Did you notice the doctor changed her chair? So these are small non-verbal skills that you learn to develop so that you have better eye contact. So that was a very good thing she did, where she turned the chair so that she could see the patient. So seating arrangement. What else? Excellent.
Excellent, yeah. Yeah, she also asked the name.
She made the environment.
Anyway, we are talking of the good things.
She made the whole conversation.
Sorry? What do you say? On what basis are you saying that? Very good.
Because listening to the what wants to, the patient comes up with all his problems, and that is, I mean, she was leading the conversation in a way that produced the patient to explain more and more about his own problems.
She was not interrupting in between the excellent. That, and she also kind of kept saying, तो अच्छा आपको ये हो रहा है, आपको blood pressure है, आपके all that. So she was actually telling it back to the patient so that the patient understands that she has heard it. So that's a great point for listening, and that is something we doctors don't do. And literature says that we interrupt patients within 1.8 seconds of them opening their mouth because we are not keen on knowing his story. We want to complete our agenda. So it's excellent point of listening. What else?
She made the conversation light by asking one bedroom or so. The kids are waking up with the snoring. So
excellent. Yeah, it is important to break the ice because patients can be at the edge of the seat. Yes. So that's a debatable thing because everybody might not like the idea of being told कि तुमको ये होएगा ये होएगा ये होएगा.
In my case, it is not debatable because I went to a sleep apnea specialist 10 years back, and he was a guy who worked with the doctor in Stanford who coined the word sleep apnea. So this guy at that time did not tell me that I might have diabetes, I might have blood pressure, I might have a heart attack. He said that you can pull along for 10 years and by 50, you can probably think about rectifying it. Now, I am at 50 today and I have got severe obstructive sleep apnea. I'm thankful to Dr. Rajan that I'm under his treatment. But had that guy told me that time to take it seriously, I would not have landed up today here. Now, I am consulting 4 to 5 different specialists, and all are of the opinion that I have to lose weight. When I went to that guy 10 years back, I was not so obese. Neither did I have any diabetes or blood pressure. But today I have them all, and the only solution now that I'm being given is lose weight, which could have been avoided 10 years back. So she was very categorical in saying that these are the things that can happen.
So point well taken.
And the patients that come to you are not laymen or who are not like from the lower strata of the domain. They understand, and everybody, almost everybody, has insurance today. Of course, it's a debatable thing that not all insurance covers sleep study. That's a different topic, but everybody has insurance and they can get treated.
So I'm asking the pulmonologists who see sleep OSA patients, how can you tell this to the patient or communicate to the patient about the consequences of poorly treated OSA in a manner that the patient gets the point and doesn't get hurt?
So,
Do you
Rajan,
have any? Yeah.
so what happens is when you're seeing the patient and as the conversation goes, at times you're able to judge how much to tell the patient on the first consult. There is a group of patients who's never wanting to accept their sleep apnea, not wanting to do anything. And if you tell them too many things, they might just run away from there. And then there are people who are aware about the sleep apnea condition and they ask you, what if I don't get it done? So it's more fluid at the clinical level. You tell them too much, they feel you're trying to sell it. You don't tell them too much, as in
So
his
that's
case.
where Kapil the spikes helps.
Right.
Perception. How
So
much
that
do you know?
invitation part that you spoke about.
Invitation.
So the thing is, when the conversation goes, you can judge where to tell them.
So this is the spikes. It helps
Right.
not just at consulting.
Yes, that's what invitation is the part.
It's not just at the consulting, it's with your wife, your maid, your son, your driver. It helps in all these situations. Please ask the patient how much they know. But what I also want after Leena finishes is to give it to Shivani to say, how will you be between, like he wanted it more direct. Kapil is saying you have to judge what comes to your face. But suppose you realize this patient को मैं सब बता दूंगी तो ये आने वाला नहीं है. So how will you frame that in Hindi or whatever to say that look, it is something you need to address, but.
So I usually, that's when I introduce the oxygen point. I also tell them that we all know oxygen is important. तो आपका कितना कम होता है उस पर डिपेंड करेगा how harmful that is. And low levels of oxygen, like you know, is harmful for all organs of the body. And it can lead to uncontrolled hypertension, uncontrolled sugar, and बहुत severe cases में हार्ट अटैक, स्ट्रोक वगैरह भी इस सब चीज़ से होता है, बाकी बीमारियां भी आपकी कॉम्प्लिकेट होती हैं, तो इसके सारे ही ऑर्गन्स पे काफ़ी इफेक्ट होता है. That's the most gentle way that I.
Leena, you wanted to say something?
I just wanted to add that, and that is why difficult conversations are like a procedure, because you probably use your judgment in different situations with different patients. So you might be able to give more information to some, you might need to be more firm with some. And this is like the way a surgeon who's operating may use more cautery in one patient than he uses in another. And that is what he develops with. See, the more you do this, the more you will develop that intuition when you're like, you'll be able to actually read the person you're talking to and understand how much should I say today. Maybe today is not the right, maybe now is not the right time to say this. But this is something important that, like for example, as you said, ethically, we do need to tell the patient the risks of not taking the therapy that we are suggesting. We have to give them complete information, which means the risk of not doing something we're advising, we ethically have to tell them at some point, but maybe not in that conversation. Maybe it's something that you will develop, that intuition of when to. Yeah, there's the fear they may not come back. That's also a risk we run.
Finished a conversation where you feel incomplete. Oh no, I should have told him this. Then I think such patients, you should really take their number, message them or call them or make your secretary do that so that you don't lose follow up. Then the patient also realizes that there's somebody else who's concerned. So this is another word I feel you can use very often and comfortably by not making the patient very anxious, is that I'm concerned about your symptoms. You are telling me you have 1, 2, 3, 4, 5, your father has died young, and with this waking up, I am concerned that you might have obstructive sleep apnea, and you kind of express the fact that you care for this by using that word, which of course you have to translate in Hindi, Marathi, etc. Some words are difficult to translate, and concerned can be a difficult word. But if you say, I am worried about these symptoms and I would like to rule out, then you take the onus on you, and then obviously it's like you have told him to do it, and then you also bring up negative things like cost, place of test only if you are put into it. It's like doing a case presentation in your MD Viva. Don't say things that you're going to be ripped apart. Saying mehenga hai, why to say? Don't commit things where they will say they will hold on to that. Patients want to hear what they want to hear. If you say 20 things, they might hear 10, they might understand 8, and they might remember 2. So say those things which you think is going to make a difference in their decision. And sometimes it helps to say, I'm very worried about what's happening to you, and I would like to do these things to see to it that it is there or not there. So that's important. Yeah.
Madam, the basic thing is to have a very, very good rapport with the patient. So I agree. But then the level of trust in the doctor and the patient, and when they feel that this person is really truly interested in my well-being, then they become more accepting. Because I am now, though I am not using this, my question comes when I am doing diabetics, where the starting injection is a great thing. We have to convince them that this is the only thing. But then the rapport, we are able to convince them that yes, this is the only ultimate thing that we have to go for.
This is something that Sujit has been saying, that the act and the science and the craft of communication has to be there in every conference, because none of us are taught how to talk, and none of us know how to get out of sticky situations. When patients ask questions, we like, you don't know what to say. Either, for example, in palliative care conversations, there are times when patients say, am I going to die? And the doctors then say philosophically, hum to sab marne wale hain. That is not the patient's. So, we don't know how to get out of sticky situations. And it's very important to get out of a sticky situation and yet convince the patient, right? So it's important, and it comes with practice. It's very interesting.
So there is something that we in dentistry practices tell, show, do. So in dentistry is one of the most feared field. No matter how strong the patient is, he might be having 28 inches biceps, but when he sits on the chair, he's sweating in full AC. So, judging the patient when he enters your operatory, we need to be important. Judging in this case scenario, wife was already exposed to lot many things is important, and then wife is exposed is a good thing. But making the husband understand that why it is important. First, to tell him that you may be suffering from OSA, then to show him probably the video which Dr. Saurabh showed, airway falling back, is a good thing, so that a video showed is equal to 1,000 words. And then tell him, let us do the test, and then we'll think whether CPAP is required or not. Even I cannot commit now or advise now confirmatively that you are a candidate for seat. Maybe just conservative lifestyle modification should work. So that gains the confidence. We need to put up all the, as the gentleman behind told, that we need to put up all the points to the patient, whether they are good for them or they do not want to hear, like you might be getting stroke, and then tell them, go home, think it over, this is the test that is required, you can go home and discuss, and if you feel your future health is important, you can come back to me and then we'll take it from there.
That is also a tricky thing to say, because I think if you feel your future health, like I think you also made a sentence like that. So how can you say that better is, like I said, I am concerned about, that makes a lot of difference. And the other thing that I want to really just let you all know is the simple thing of, if you ever get stuck in a situation, ask what or why to get out of it. Why are you saying this? What is making you say this? So then, you equally get out of the situation. One last point till we go to the other thing. We want somebody to volunteer as a doctor for the next role play, please.
My suggestion was that when you are having your folders of prescription, maybe you can do a two-page write-up on the either side of the folder describing what sleep apnea is and the effects that can
So
have.
like a take-home, give a leaflet.
Yeah, the patient should be aware of what he's entering into and what will happen if he doesn't take it seriously. I think that is the best way of communication.
So, the other thing that you need to remember is, therefore, from this, is when you have to disclose a report to the patient or when you have to discuss further management, please slot your appointments accordingly. Because if it's going to take time, it's not fair for the patient to be rushed. So you keep it in the beginning of your consult or last of your consult, And believe me, if you practice and master spikes, it doesn't take time. Like I always say, a good communication is always remembered, a bad one is never forgotten. So if you do it right, it doesn't take time. Keep it. So when you know this patient is coming with a PhD report, you know the kind of patient he is, slot him in such a way that you need that extra time. See, these are the requests that is very important because sometimes people need convincing. So on to the next role play.
Next role
We
play.
have our
Hi Ashish, how are you? Fine, thank you. और कैसा चल रहा है अभी सब मजा नहीं है हाँ मजा नहीं है सबकी दवाइयाँ चल रही है आपकी डायबिटीज वगैरह सब चल रही है हाँ सर डायबिटीज का तो दवाई चल रहा है ब्लड प्रेशर का भी चल रहा है और अपनी सीपैप की मशीन आप वापर रहे हैं रोज सब कोशिश कर रहा हूँ वापरने का लेकिन वापर नहीं पा रहा हूँ मैं क्यों क्या हो रहा है सर बहुत अनकंफर्टेबल फील हो रहा है और नींद नहीं आती है ऐसा लगता है कि जैसे चोकिंग कुछ होगा तो एकदम से मास्क निकाल देना पड़ता है अब एक रात को तो मैं ज़बरदस्ती 11 से लेके 4 बजे तक यूज़ किया लेकिन मैं सो नहीं पाया मैं जाग ही रहा था ये आपका मास्क कितना पुराना है अभी मास्क तो सर पुराना नहीं है मैंने नया मास्क लिया ओरिजिनल मास्क लिया है जी रेस्पेड कंपनी से तो मास्क तो पुराना नहीं है लेकिन मास्क के बाद मैंने दूसरा मास्क भी ट्राई किया तीसरा मास्क भी ट्राई किया नेजल मास्क ट्राई किया लेकिन कोई भी मास्क मेरे को सूट नहीं हो रहा है तो जब आप बोल रहे हो सूट नहीं हो रहा तब तकलीफ क्या हो रही है आपको सर मेरे को चोकिंग इफेक्ट आता है एंड दूसरा क्या आई एम नॉट यूज्ड टू दैट एयर प्रेशर सो बेसिकली आई थिंक दैट इफ आई एम गेटिंग द एयर प्रेशर देन आई थिंक आई एम नॉट एबल टू स्लीप आई एम बेसिकली इट्स डिस्टर्बिंग मी द एयर प्रेशर is disturbing me and my sleep. In fact, the moment I remove my mask, I fall asleep. Okay. तो ये मशीन तो आप पहले काफी टाइम से वापर रहे हैं, राइट? सर अभी 1 महीना हुआ है. अभी 1 महीना है. हाँ. इसके अलावा अक्सर नाक जाम वगैरह कुछ रहता है आपका? हाँ सर नोज तो जाम रहता है. एक्चुअली मेरा लेफ्ट सेप्टम कंप्लीटली 100% डिविएटेड है. तो इस बात के लिए किसी ईएनटी को वगैरह दिखाया था आपने? जी मैंने दिखाया एक्चुअली 2 ईएनटी को दिखाया 2 अलग अलग ईएनटी को तो दे आर ऑफ द सेम ओपिनियन दैट यू शुड फर्स्ट लूज वेट देन यू शुड कंसीडर सेप्टोप्लास्टी नॉट बिफोर लूजिंग वेट. और वजन का क्या हो रहा है? आप डाइट प्लान फॉलो कर रहे हैं? 10 साल पहले जब गया था ईएनटी के पास तो उसने बोला कि यू कैन फॉलो अलोंग विद दिस नेजल डिविएशन एंड स्लीप एपनिया. And in the meantime, I have put on 30 kilos of weight, and now I am at a situation where I'm not able to lose weight, and my diabetologist is trying to impress upon me the need for taking Ozempic, and I'm wondering whether to take Ozempic or to lose weight through yoga or through other things. Okay. और अभी ये जो CPAP की मशीन आपने लोअर प्रेशर पे ट्राई की है क्या आपने? लोअर प्रेशर पे मैंने रिक्वेस्ट तो किया था बट अभी इसमें भी थोड़ा सीन हो गया कि मैंने जब टाइट्रेशन के लिए टेक्नीशियन को घर पे बुलाया तो उसने 4 और 12 पे रख दिया एंड सो गया वो. तो मेरे को उसको जगाने का मन नहीं किया. फिर दोबारा वो आया दोबारा वो सो गया और मेरे को बोला कि आप सोना आप मास्क मत निकालना. So I couldn't adjust to the mask, so I had to remove it. तो मेरे को लगता है उसकी स्लीप शेड्यूल करना बहुत ज्यादा जरूरी है आपसे. Probably that may be the case. बाकी फिल्टर वगैरह सब चेक किया है? Yes, ओरली तो उसको पूछा गया था कि भाई फिल्टर फ्रेश है क्लीन है तो उसने हाँ बोला था और मास्क मैंने उसका भी यूज किया मेरा भी यूज किया. और नेजल मास्क नेजल पिलो किसी से भी आपको कुछ फायदा नहीं हो रहा? बिल्कुल फायदा नहीं हो रहा है. नहीं. तो अभी कैसा है ना कि ये सिचुएशन है स्लीप एपनिया तो है आपको? हाँ सर. ओवरवेट है. हाँ सर. डायबिटीज है. और स्लीप एपनिया की जो बीमारी उसका मेन ट्रीटमेंट सीपैप है. राइट. पर अगर आपको जरा भी सूट नहीं हो रहा है तो मे भी अपने को ईएनटी से रिविजिट करना पड़ेगा कि ये जो आपका जो डिविएटेड सिग्निफिकेंटली डिविएटेड नेजल सेप्टम है क्या वही तकलीफ दे रहा है आपको सीपैप यूज करने में? करेक्ट. क्योंकि नॉर्मली जो पेशेंट होते हैं किसी को मास्क वापरना है. अभी पहली बार कोविड में किसी को मास्क पहनना दिया गया है तो उसी से उसको जमा नहीं है तो लोग हमेशा डरते मास्क वापरने के लिए. पर अगर आपको फेशियल मास्क नेजल मास्क और नेजल पिलो से भी तकलीफ हो रही है तो मेरे को लगता है अपने को एक ईएनटी को वापस मिलना पड़ेगा और मे बी वो सेप्टोप्लास्टी करके वो आधा प्रॉब्लम तो वो सॉल्व हो जाएगा जो आपको मांस का इंटरफेस का इशू हो रहा है, और वजन कम करना ज्यादा जरूरी है साथ में, और इसी दौरान अपने को वापस सीपैप के ऊपर ध्यान रखना पड़ेगा.
I am of the firm opinion that the diabetes, the blood pressure, and the weight are all a byproduct of the sleep apnea, which I had since last 10 years.
100%.
And now I'm in the situation whether to first look at the egg or the chicken.
So it is like a vicious cycle.
Yes.
Obesity हुई, obesity से sleep apnea हुआ, obesity से diabetes है, obesity से blood pressure है, और अब ये चक्रव्यूह बन चुका है कि चारों चीजें एक के अंदर एक लिंक्ड है. सीपैप आइडियल ट्रीटमेंट है, पर आपको सूट नहीं हो रहा है कुछ भी कुछ वापर के, तो एक अपन ईएनटी को मिल सकते तो सेप्टोप्लास्टी पैप करेक्ट करके सीपैप काम करेगा कि नहीं. इन द मीन वाइल इंस्पाइट आपकी दवाइयां चालू है और डाइट कंट्रोल पे भी वजन कम नहीं हो रहा है, तो वेट रिडक्शन पे भी अपने को कॉन्सेंट्रेट करना पड़ेगा. तो इसके अंदर ही जो नए इंजेक्शन है उनका ट्रायल लेने में कोई हर्जा नहीं है, क्योंकि कम से कम वजन कम होगा तो सीवियरिटी ऑफ स्लीप एपनिया भी कम होगी. टिल दैट टाइम सेप्टोप्लास्टी भी काम करेगी और फिर अपन देख सकते हैं कि कैसा रहता है.
इसमें और एक बात आपको शेयर करना चाहूँगा कि जब मैं गया मेरे दूसरे डॉक्टर के पास, तो उसको बोला मैंने कि मैं नहीं शूट कर पा रहा हूँ मेरे को मशीन, और तो he said probably you have anxiety and you have depression, so I think you should consult a psychiatrist.
No. So I don't feel कि it is anxiety or depression.
A patient also becomes a psychiatric patient the moment he doesn't, get suited to the mask and the machine. So these are all very, 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 fine lines where then the patient gets confused completely.
नहीं, तो तकलीफ है आपको, स्लीप एपनिया 100% है, ट्रीटमेंट भी आप लेने के लिए इच्छुक है, पर आप इतना ओपन माइंड करते हुए भी आपको जम नहीं रहा है, तो डेफिनेटली अपने को देखना पड़ेगा कि और क्या चीज है जिससे आपको सूट नहीं हो रहा है. तो जैसे आपने बताया कि डिविएटेड नेजल सेप्टम है, तो वो एक कारण हो सकता है जिसके कारण आपको मास्क या कुछ भी सूट नहीं हो रहा है, तो वो एक पॉइंट अपने को देखना पड़ेगा. मे बी एक दूसरा एक ईएनटी ओपिनियन लेके अपन डिसाइड कर सकते हैं उसके बारे में. एंड एंजाइटी डिप्रेशन आई डोंट नो, आई गेस बाकी की चीजें होने के कारण डेफिनेटली यू आर मोर अवेयर अबाउट योर सिचुएशन and you want to do something about that.
Right, sir.
Yeah.
Very well done. So you're getting a gold medal from everybody else.
You want my sleep apnea to go away.
So that's another interesting thing. So it went very well, but he got psychiatry. So I want to ask Shivani this: how do you ask for mental health? And I think it's very important for us because of the fact that in our medical training we do not have even an hour session on communication, and communication on these sticky issues of mental health, sexual health, which is very common for respiratory conditions, we just don't ask. And very often if the patient doesn't bring it, we don't bother to say. And the patient is trying to say psychiatry, depression, we brush it under the carpet. So it's not right or wrong. It's something that we are here to learn from. So how do you elicit mental health issues in sleep and sexual health issues in sleep?
So given the situation that you are in, sir, I would firstly tell them that I see very few patients who are so aware and conscious of their problem to this degree.
Mic is on. Change the mic.
So I would like to first compliment them that the very few patients that I come across were so conscious and aware of their problem, and I would always also tell them that
Something to do with you and the mic.
I think so, but I think I'm quite loud and audible even without the mic. So of course I tell them that it can be extremely, give a lot of anxiety to the patient, and it can obviously very disastrous to go through all of this because you understand the problem and then you're not able to tolerate the treatment which we always label as the gold standard. So just to have a little bit more patience and that we will be able to sort things out, you will just have to probably stay with us a little longer. And I also tell them that if you want, I can speak to your ENT and discuss with him how to go forward. Or if you want, I can probably refer you to my colleague and discuss with him before I send you to him so that he knows the background. So
What point I was trying to make is that when a sleep apnea patient goes to a doctor and the doctor is not able to assess why he is not able to fit in with the CPAP, the doctor feels that he is anxious or stressful, the patient, and he sends him to a psychiatrist. Now, this is where the deviation happens, and this deviation is completely uncalled for. And what happens is, if the patient is not mentally ready to accept the fact that he may or may not have psychological issues, we'll completely send him away from the treating doctor as well as from the other things that can be sorted out.
So we have a tool
was
for that, absolutely. We have a tool for that.
Yeah. So what she's trying to say very correctly is to acknowledge the distress of the patient. So any emotion that your patient is displaying, like disparity, irritability, anger, you acknowledge. I can see that this is causing you so much distress. And sometimes if you say things like, I understand, people can actually pounce back and say, how do you understand? You don't have sleep apnea. So you can say, I can imagine how stressful this must be. Unable to sleep, you're not able to, you have blood pressure, you have diabetes, you have so many things going on. I can see. So acknowledge the distress of the patient. Automatically, 50% of the stress level in that room becomes less. So you can say that I can see you're upset, I can see your distress. So that's what Shivani is trying to say. But the other thing that is important is when he also asked us then, that doctor didn't do. How do you say that? Very often there are patients who come and say, वो doctor ने तो कुछ बोला ही नहीं. How do you get him out of that situation? Any suggestions?
So I always tell them that even when we sit at home and five people discussing a problem, everybody has a different take on it. So, everybody has a significant different thought process. So his thought process may be different from mine and yours, and there is no right or wrong.
Because it helps not to put the other doctor down.
Yeah.
It's best not to, it's best to respect each other.
So we can also see that at that time the situation may be different and your doctor assessed you at that time.
But please acknowledge the fact
Yeah,
that
yeah.
he's lost the 10 years.
Right, right. So exactly. So that is true. Right.
Yeah. So we'll discuss a tool.
So it was very new, but had he been categorical at that time, because I had the money
Yeah.
at that time, I had the weight that ever I did not have diabetes and blood pressure in my body. But then I took it lightly. And today I'm in a situation where instead of addressing sleep apnea, I'm required to address my weight. My blood pressure.
Right, but then that is what we would tell the patient ki at that time the doctor probably did what was the protocol at that time, or each doctor assesses to the in different times differently.
Doctors would not hard sell anything. Or they will not go out of their way to insist on a surgery or a sleep study, even today.
Yeah, but
Doctors
these
will
are
not go out of their way to market or the sleep study, but for for the information that I have, sleep study doesn't cost a bomb.
correct.
So I am adding to even Dr. Mittal's point. I would like to come. There was one gentleman here who stressed the need that it should be undertaken as in the part of the health checkup. Now, believe me, sleep study is available for 2,500 rupees.
Yes, yes, I agree with
And
you.
when we go for dinner or lunch, it costs us 3 or 4,000 rupees. So you have to inculcate it, and it is not very difficult to convince the patients to do sleep study.
So, but you are on that side of the fence. There will be patients who are normal. So you will, because you are on the sleep apnea.
No, the take home from this also is that we doctors need to learn to communicate also.
Correct.
I'm not saying
All
better
the
or worse.
time, all
So
the time.
for that, Leena has some more tools.
One more tool to share with you.
So it's true. This is a great take-home point that we doctors need to train ourselves to talk, to convince, to break news, to explain the trajectory of treated or untreated illnesses. Yeah, Kapil, your last word, and then Leena.
Sometimes what happens as a doctor, we do land up making a judgment whether the patient will be wanting to do, not wanting to do, can afford or cannot afford to do. So I guess
That is something we should just try to get out of it and try to tell them what are the options available at that point of time. Now, whether they choose it or not choose it is their prerogative. Like for him, in retrospect, he would be like, even if it was 20,000, I would have done it. It saved him so much of this. So in retrospective, so what happens is that sometimes we may have to just say, this is what you want to do, and then if the patient is not wanting to do, then you decide.
Another way of saying is, I'm sorry that you had to go through all this. So, but let's now discuss. Yeah, correct.
Yeah.
So that is also important. You don't have to apologize for the other person's deed or misdeed, but you acknowledge for the distress that he has gone through, which is genuine.
Yeah.
You wanted to say something, Neha? You want to start?
I'll just.
If I can just add to. Thank you. Yeah, if I can just add to that discussion that went, I would say, first of all, I really appreciate I'm having such an educated patient over here who's understood all these things and has understood the implications of this. So I guess you probably understand the importance of a good undisturbed sleep. And since now you are trying to work on reducing your weight, which is becoming difficult, and you also know that the relationship of your weight is with sleep apnea, which you want to correct. So how would you break this? So I would say you should meet a pulmonologist like Dr. Shivani, who would give you some other newer, latest options. That is one point. Take another ENT opinion. And probably what is happening in the Western world today is the dentists have become a team along with the sleep physicians, where there is one small device which you can use, which will physically bring your lower jaw in the front and your tongue in the front, which will physically reduce the obstruction. And so maybe your CPAP can become more effective. You said you tried all different masks. Fantastic. But maybe because of that obstruction being more severe, your masks may not have worked. So one of the ways you can try and find out is there are about 150 types of dental appliances which are now FDA approved. So maybe some kind of an appliance which can help keep your jaw in the front, make your airway patent, and give you more oxygen.
Yeah, we heard about that in the morning.
I
Yeah.
need to.
Yeah.
I just need to tell you the risk of continuing this discussion, and that is that we lose two role plays. Okay, if we're all okay with that, we continue.
Can we?
Otherwise, we move ahead. So
Just,
we move ahead. Okay.
just one point I want to make, that it should be a holistic treatment of sleep apnea. It's not only CPAP. CPAP is after all just pumping air into your choked airway. But if your airway itself is so badly choked because of fat and other things, it will not work. Your muscle strength is also important. So doing exercises like myofunctional exercises, your inspiratory muscle training also makes a huge difference. Or if these things are not attended, and food wise, obviously there is some mistake going on without which one will not put on so much weight. So the cutting down the calorie intake is very important. So you may have to go on either intermittent fasting or something like that.
We'll get.
To continue get the doctor gentlemen to do this thing. I'm also trying to work on the breath. I've joined a breath coach. Yeah.
Okay.
He's also helping me to breathe rightly. And parallelly, I'm also fighting with my insurance company to get everything covered. And I filed a legal case against my company.
Great.
In the insurance.
Thank you so much.
Yeah. Okay.
Thank
Over to you, Leena.
Yeah. So it comes to this brings us to the next tool, and that is again an acronym for nurse. It's the tool for empathy and communication when handling emotions and reactions. Okay. So what we saw in this role play was understandably very strong emotions. Okay, there were very strong emotions, reactions, and there is a tool for us to be able to address this. Okay, so first, it's important in our mind to name what that emotion is. We need to name it for ourselves and for the patient by saying something like, I can see that you're feeling very, like it can be something, I can see you're feeling upset about how something was handled earlier. I can see that there is a sense of regret, loss, whatever. Just name the emotion, all right? Understand the emotion. It's very important to also say, as Dr. Rajam said, sometimes when we say, I understand, it may trigger the person. They may say, but how will you understand this? You've not gone through this. But basically, we express that we are acknowledging that emotion. We can see it there. We give it a name, we understand, and we respect it, okay? We would never say to someone, you shouldn't feel like that, or I don't think it's reasonable that you feel like that. Those are things that we would not say. We respect it. We say that, again, by validating their feelings and by letting them know that we are hearing them express that emotion, and that it's okay that they have expressed that emotion in front of us. Again, we will develop the intuition for how to deal with this. For example, many times, especially in palliative care, we hear patients expressing pain or regret and saying that another doctor did not pick this up, okay, another doctor failed. And they almost look to us for a validation of that. So oftentimes we have to say that, we understand your anguish in this. We wish it was different for you. And as ma'am said, that maybe that doctor had a different perspective, and this is the perspective that I can offer. Support the patient definitely, okay? See if there's still something available for that person. As Sir said, we were supporting the fact that this ENT, the deviated nasal septum, may be an issue, so let's revisit that. Would it help if I speak to your ENT surgeon, if we see if there's some way forward, and we find some way to support this emotion, all right? And explore all the possibilities. So as we had lots of feedback from the audience, explore whether other modalities might help as well. So of course an ENT referral, but maybe also a dental opinion, maybe some kind of yoga and breathing techniques, a diet opinion, like different opinions. Let's explore those. And then, of course, this would tie in with your spikes model. So at the end of your consult, you will once again summarize that discussion so that the patient doesn't leave feeling a little confused about what just happened in the room, right? So you again will summarize and give them a definitive thing like an ENT referral or the discussion that let me speak to your ENT surgeon and we'll reconnect in a week and I'll let you know how it's going forward. Okay, so that's the second tool. We go to the third role play.
The last one for the afternoon. We need a doctor and a patient volunteer. And Aditya, are you coming forward?
And once again, thank you to everyone who's participating so far.
Yes. Okay. You have no choice. And the doctor, somebody is not so hungry.
There you go, yeah. So what
We
we
are
have is
between
active volunteering
lunch
and
and-
passive volunteering. So if you don't volunteer, then we volunteer you.
So, doctor, you're meeting a 38-year-old busy corporate with a jet setting like frequent travels, suffering insomnia, popping sleeping pills on his own. Your task is to caution regular pills, advise sleep hygiene. Good afternoon. मेरा नाम Dr. Anupam है.
Yes, madam.
Please turn towards me.
Yes, ma'am.
बताइए आपका नाम क्या है?
मेरा नाम प्रखर है.
ओके प्रखर.
एंड मुझे बोला है कि आप एक स्लीप डॉक्टर से मिल लीजिए. बट एक्चुअली I am doing fine. I am doing okay. Only thing is I am not able to get my medicines. I take Zolpidem.
Okay.
And every day I take Zolpidem. I am feeling very happy.
Okay.
And I'm rested well after that. And it's because I have to travel so much, I really need those medicines. But I'm not able to get it without a prescription.
Tell me more about yourself, why you travel so much?
So I am in a corporate job.
All right.
And I need to travel different countries. Almost every 15 days I am in a travel mode.
Okay.
So there is so much shift in my day-to-day, day and night sleeping that I need to take it. And of course, you know how corporate jobs are, madam. Okay. It's so stressful that without help, it wouldn't be easy for any corporate lawyer or corporate person to sleep without a help now.
So how long have you been taking these pills, and did you consult any doctor before
6 to 7 years I am taking this.
Okay.
Yeah, it was prescribed by a doctor.
Okay.
My GP had suggested first,
Okay.
and then over the course, I have been prescribed this by the other doctors also.
So you just show the same prescription, go to the pharmacy and keep taking it. Is that so?
Yeah. The pharmacist knows me,
Okay.
and I don't abuse, madam. I take it only because I need it.
So what do you mean by you don't abuse it?
I just take once in the night time, and after that I don't take it. But that night time I do need it because it won't be. I will not be able to sleep.
So what happens after that?
So once I take the medicine, my mind goes silent, and I
Okay.
am able to get rested sleep.
Okay. You cannot do without it.
I cannot. I can try, but I've tried a few times, but it doesn't make sense because I'm wasting so much time just trying to sleep, and the next day are so important that I will maybe lose on my business. So I need to be upright always, to be able to handle client queries. So I cannot mess up with my sleep.
So have you had any situations where you have to increase your pill intake or increase the dose?
So that has not happened, madam.
It's the
I'm
same pill for the
Zolpidem
past
taking only 10 milligram. Clonazepam I take SOS whenever I feel ki I'm not able to sleep, but that is not every day. So when I'm very stressed or I've traveled a lot, so those days I need SOS clonazepam. So I will need almost 5 to 6 days in a month, but not more than that.
Are you suffering from any other problem like high BP, diabetes, thyroid
No,
issues,
nothing.
or anything? So, have you tried anything other than pills which can help you?
Maybe initially I had tried to not take the medicine, but everything failed. So I tried yoga. I have tried taking chamomile tea
Okay.
and not using a mobile phone initially. But it was 6 to 7 years back, madam. I was just starting my career, and I needed to get it on track, so I had to take the medicines.
Okay. Has it affected your relationship with your family members? You taking pills? Does your family or bed partner
My
know
wife
about it?
doesn't particularly like that I need to take the medicine,
All right.
but she has also understood over the years that it is so important for me. So now we don't have a discussion about it.
You don't have a discussion about it.
No.
So I need to ask you a little more private questions. May I?
Yes.
So has it affected you in your personal, intimate relationships, or any other mood changes have you had along with it?
Little effects are there because uh, I need to match the timing of taking the medicine, and I'm not able to perform well if I've taken the medicine. I can say that that has happened, but of course, mood, so it is fine after I take. But if I don't take it, I'll be jittery. So I have to take it, maybe because of the job and the stress.
So do you think you will be able to take it forever? You would want to take it forever?
Unless I get a better solution for that.
Okay. Are you aware of what the pills can do to you which are not good for your body? Like the side effects?
I know there is some side effect about memory,
Okay.
but if I'm not working now, what will I do with my memory? I need to work also.
That's true, sir. So how do you think I can help you, and what can I
Just
do
give
for
me
you?
the prescription.
Okay.
I'll be happy.
So I'll give you a prescription for a short while, but I would also want you to try the already tried methods and see if it can help you with. Like there is something called as sleep hygiene, like you already mentioned, not using the gadgets and the avoiding lights, or you can reschedule your travels. or something like that? Would you be just think of it at what are the avenues for you to make small modifications in your routine so that you can avoid the pill, if not on all days, at least for 2 or 3 days in a week?
So I have tried doing that. I have actually tried doing it. But madam, ultimately with the stress, ongoing work pressure, I again need to take it.
We can address that also subsequently, but I would like you to.
Madam, how will you address that stress? My job is so stressful. I cannot change the
I
job.
understand that. So we will involve a psychologist also along with that, and we will go step by step.
Psychologist can help in my sleep. You think it will be good source? I can go, but I don't know. Can talk therapy improve my sleep?
It would definitely improve, but we will try these small steps one at a time. And if you are not satisfied, definitely I'll give you the pill.
Okay.
So, are you okay with trying this?
But if you are very sure it will help and not hamper my next day.
To the best of my abilities, I think it will help you, and without causing any adverse effect on your overall health and the health of your family as a whole.
So what steps you are suggesting, madam, to not take the medicine?
For right now, you can take it for 2 to 3 days.
Okay.
I'll give you 5 mg instead of 10 mg, and also I'll give you a handout in which you can practice certain things and you can avoid certain things before you can go to sleep. And also because you're traveling in different time zones, so I'll also give you a handout on how to deal with that without taking any medicine. And we can come back after your next travel and we will discuss it again. Is that okay?
Yes, ma'am.
Thank you, sir. What's your feedback on? I felt actually good trying to do that. I used that spikes model and it was helpful. Trying to understand parts of the nurse and
I noticed the warning shot. He said, I'm going to ask you something. I'm going to ask you something personal. She said, I'm going to ask you something personal. I'm going to ask you something difficult. Is that okay? So that was giving a warning shot. Okay. So she was using a bit of warning shot and also using invitation. He said, yes, it's okay. And then she could go ahead. Okay. So we saw that you are already using these tools. And how did you feel?
So I can say as a patient, she could actually convince me to try a different method, which I was reluctant initially. I had tried already, but her empathetic approach, her understanding of my problem, she did not say that you have not had tried properly. There was no blame game or finger pointing. She did try to understand and suggested that it can help. Although I did find that, of course, you might not be of this specialty, madam, but a more confident answers about certain questions about how it will actually help, how psychologists will actually help. So this would might have motivated me more to go ahead with full confidence. But I felt heard, I felt understood, and open to try changes. And I also realized the problem, some intimate problems which she brought up during the conversation. So she made me realize that this is not a good and long-term solution.
I think you did a wonderful job. Yeah. Excellent. And the other thing which I think helps is that when he was sounding reluctant, is to say that, we are in this together. I'll support you. So small things like that. But you did everything to show him that you will support, and you kind of reiterated what he said, and you said small steps at a time. We'll keep coming back and addressing this, etc. Sometimes also as doctors, we might not know everything about the subject, but yet we can communicate that well, in the sense, like you said, psychology. So you can say, if you actually judge that she couldn't explain the importance, maybe she really doesn't know, maybe even I don't know what's the importance. So how do you get out of it is that, I am also not very sure of how a psychologist can help, but why don't I talk to the counselor or the psychologist. And if there's something in which I feel you will benefit, let's go ahead and do it. See, sometimes you might not know everything about everything. It's impossible. So it's okay to acknowledge that I'm not so sure how this will help you, but let me have a chat with the psychologist. I will get back to you, and maybe you think it's so. These are the things that you learn on the go and on the ball. And what we are trying to tell you, these frameworks are just frameworks. It is not aisa hi karo. Everybody has to adapt their way of communication with their comfortable. You might not be able to say things that this young doctor said about sexual health, mental health, the way she said it. Some people find it uncomfortable. You have to find your own way of saying things so that you are not squirming in your seat and the patient is not looking at you squirming. So what I'm trying to say is develop your own method, use these tools. There's one more to go, which Leena will say before we go break for lunch, break for the day. But the important thing, it's okay to tell patients ki, I really not sure how this will help, but I think let us explore it. Let's come back. We are in this together. I will support you in whatever way. Is there any other way you want my support? So these are the ways of saying and keeping him engaged so that he comes back to you also and goes back convinced.
Thank you, both of you all. Actually, there's one thing I sensed with regular sedative use. What I often do is I get very irritated, actually. And maybe this is my mistake. I become judgmental and, look, what are you doing? And I would direct a lot of anger to the primary care physician who prescribed it to you in the first place. And obviously, that's not the right thing to do. So can you tell me, how to improve that?
I think one of the things, Sujit, we often do is belittle other doctors. I think that makes the patient respect you less. I'm not saying you as in you, the person who's belittling the doctor. Because one doctor is bad mouthing the other. It really doesn't help.
I'm seeing he's desperate for the prescription.
Correct.
And I'm cursing the doctor who prescribed it.
So the way to say it is, I don't think that's the only way you can do to solve this. Yes, I realize you need these medications to go to sleep, but I think we need to explore other options available today in a more detailed way. For that, maybe you'll have some periods of being uncomfortable. I agree to that, but let's work together and do step by step, one day at a time. Because I think it's very easy to trash somebody else's prescription. It doesn't help the situation. You are really not helping him. It's like him getting a validation ki, haan, that doctor ne galat kiya.
But Prakhar, you must be seeing so many patients who are abusing sedatives. How do you deal with the primary prescription? Obviously you also, I'm sure, don't badmouth anyone.
So, first thing, I make sure that I never try to judge the prescription, and I never tell that patient that this is a wrong prescription, because I believe that no doctor wants harm of a patient. He must have realized that's the need of that hour. And second thing, when I see a lot of medications and maybe just few sleeping pills, I just say that these pills you're taking, it's helping right now, but these might have a long-term side effect. Then the person asks, what is the long-term side effect? I can say there is a memory impairment, or they then say, yeah, I'm facing some. Okay, so what is the next step? The person has a query. So there are more ways to help you sleep, not with the sedatives of benzodiazepine category. There are 5 types of medicines which can help you sleep. And addressing the primary cause of the sleep can actually remove it from the root. Then the people are more interested, because everyone wants to be removing the illness from the root.
Yeah.
When we talk about taking off the problem from the root, then it is an interesting thing. And then they come on board. And then I definitely warn them about it will be difficult, it can be withdrawal, that will take time, it will be slow process. Of course, to taper off a benzodiazepine, it takes a lot of time, because we have to first shift from a short acting to a long acting. Then the person should adjust to that. From a long acting, then we remove 10% to 25% every 2 weeks, 2 to 3 weeks. We provide the psychological support, we provide reassurances, and then the person over the time with therapy, with other medicines, feel comfortable to remove. It takes 6 months of time.
This is another way, like the first role play, to say, like, instead of, if you're not comfortable saying, I'm concerned about the side effects, you said, in my practice, I have seen that untreated leads to many complications. Would you like to know about those? Instead of saying you can get heart attack, So these are all ways, you devise on your own. So that's a good point that you got, that dropping that bombshell gently, saying, you can lead to other things, and then they're interested to know. So then it's like giving an invitation.
And to answer Dr. Rajan's question about how do we not direct anger against the doctor who gave the prescription? Yeah. So because I sometimes get, a patient who's on a cocktail of medication, and literally it's a cocktail. So, and I can't say that doctor shouldn't have done this or whatever. So what I say is, I don't understand the rationale behind why the doctor put you on this. And unless I speak to that doctor, it wouldn't be fair of me to judge. But if you're under my care, this is not a combination I'm comfortable with. So, can we revisit this combination? Would you like to connect with your other doctor and, would you like to continue with that, or would you like to have me revisit? But this is not a combination I would be working with. So I kind of just, yeah. And I also try to make it a little collective responsibility. So I also say to the patient that perhaps the doctor had started it for a certain period of time. And if we didn't follow up with the doctor and get it reviewed, maybe that's why this has continued for so long. Because sometimes a patient will be using, I have a patient from Delhi who's been using the same prescription for clonazepam for the last 6 years. And I don't know which pharmacist is giving her the medication, but she's able to access it. Yes. So, I mean, it's not the doctor's fault. Maybe the doctor gave it only for a month. She had a knee replacement surgery. She was given some sleeping assistance for a month after that, and she continued to use the medicine. So it's really collective responsibility, right? There were so many people involved who are giving her the medicine. So, but that would be my response to it. I would just say that I'm not comfortable with this. So we'll just finish the last tool. But
everybody is hungry.
Yeah, I know. So the last tool, go very quickly. It's just when a tool in a significant event changes the trajectory. So in this case, he has always been accessing his medicine, and now he's not able to access it without that prescription. So he's now come to the doctor. So she has to reframe the situation. She has to understand why he's taking it for so long, whether there's something that has to be, reframed. So she could use that point to now reframe the way he's handling his insomnia and maybe try to introduce sleep hygiene and introduce some other thoughts. Expect emotions. So again, he will say, well, this is just not going to work for me. Whatever you're telling me is not going to work for me. There'll be some, sorry? Yeah, just give me the prescription. I once had a patient say to me that, is it ethical of you to charge me for an appointment and not give me the prescription I'm asking for? So I said, okay, if you don't want to pay for the appointment, that's fine, but I'm not giving you the prescription. So expect emotions. Map is basically like what she did, map a way forward. Because if you're going to reframe a therapy for someone, and that person has been used to a particular way of doing things, was used to taking his sleep medication, and now you're going to tell him that you're giving him another option, you have to give him a map. Because otherwise he doesn't know how he's supposed to go forward with this new idea. So map it, as she did, with short-term goals. Let's first speak to the psychologist, let's start sleep therapy, and if it doesn't work, come back to me. We'll see how to take this forward. Align the treatment with values. So the patients, not so much in this case, but sometimes patients have certain values that they will go by. So they'll say, I will not do this, or this is not something I'm comfortable with doing. So make sure that whatever you're suggesting is aligning with their values, and obviously propose a plan. So propose a plan kind of links back to the S of spikes, which is summarize. So summarize and give people a plan to work with, okay? So that's just the third tool. And as Dr. Rajan said, these are all just frameworks that we're giving you, but they sometimes help when we're handling a difficult conversation. It helps us to fall back on these frameworks, okay?
Just to end, a lot of things unsaid also speaks volumes. So sometimes being quiet, listening, nodding, eye contact, body language, you touching the patient at appropriate time and appropriate places in appropriate settings, these make a lot of difference. Sometimes we feel we only have to talk to communicate. Sometimes just keeping quiet, there's a lot of work. unsaid things, non-verbal communication also plays a huge role. So just go back, see how you talk. You know, when we did courses in communication, we used to stand in front of the mirror and see how we look. How do we look empathetic? Do we look like we care? All these things make a difference because patients are smart. They understand body language. They understand the confidence. They understand unsure territory. So it's okay to acknowledge that you don't know. It's not that it's wrong. How can a doctor not know? We are also human. The point is we really need to come to the level of the patient. In India, what happens is that we are put on a pedestal, so we automatically feel that we should know everything. We are paternalistic, in my experience. So all that has to change. We have to come down to the patient level, no medical jargon, talk what the patient understands, ask if he's understood. Sometimes it helps also to tell the patient, tell me what I told you, so you know that the patient has understood. Because very often in communications outside the ICU, we finish for half an hour and the patient says, कुछ serious तो नहीं है ना doctor, सब ठीक हो जाएगा. So it happens all the time. And it's not that the patient is not understood. Sometimes you have to think, I have also not communicated it right. In the patient's framework, if you will agree, outside the ICU, there's no bandwidth to listen to so much gyan. Loved one is inside, you don't know whether he's going to live, die. He's not in a position to absorb all that you're saying. So it has to be broken down, it has to be in his language, and it has to be tell, ask, tell, so that he's understood you. So this was just a little kindling of how we can all change our practice and how we can all become the best in what we do. It's so important to talk because I think that's how it convinces the patient of what you want him to do. So thank you so much for staying back and sorry for delaying your lunch.
Thank you, Rajam. Thank you, Leena. And I want to wrap up in a minute. Literally, I need to thank the faculty more than anyone else. Rajam, Leena, Shivani for staying on. Saurabh, who had to catch an early flight. Prakhar and all our without our faculty and content, there's no meeting that can happen. I think that's so important. We wanted to keep it a half day. Sorry, I delayed your lunch by half an hour. Also, all the actors who came and performed so well here in front of the audience, and through which we learned a lot. I would also recommend that everyone signs the register outside to get your Maharashtra Medical Council credit points. Some have entered the hall and not signed, so just a reminder on that. Thank ResMed immensely for funding this meeting, Subhashish especially to help fund this meeting. And without them, we wouldn't have been stimulated to do it, and we hope we can do more such meetings in the future. And finally, of course, Pratibha, Aditya, and Sheetal from the Breath First Foundation, which we run together for ensuring this meeting takes place, designing the content with me, and ensuring everything, and of course the audience. Without you guys and Ashish, my patient, for agreeing to come here and act out that scenario, which is very common and challenging. So thank you all of you all for being here. I won't delay more of your time from lunch. Thank you. Yes, I mentioned that. Those who haven't signed the register for the Maharashtra credit points.